To the public board meeting of the North East and North Cumbria Integrated Care Board on the 28th of March 2023. I'm Liam Donaldson, the chair of the Integrated Care Board, and I'd like to start by announcing the apologies for absence. Deb.
Thank you, Chair. Apologies for absence have been received from Nicola Bailey, Anne Workman, Councillor Shane Moore and Professor Graham Evans.
Okay. And I'd like to welcome members of the public who are in attendance at this meeting. And then, Sam, you have a brief announcement to make.
Thank you, Chair. Following an open and competitive recruitment process, I'd just like to announce the two final appointments to the executive team. The first is Levi Buckley, who will be joining us from North Tees Hospitals Trust as our Area Executive Director for the North of the ICB. And also congratulations David Chandler, who has been appointed as our Substantive Executive Director of Finance.
Congratulations to them. And we're on to declarations of interest. We have already forms from all of you listing your affiliations and declarations of interest, but are there any other declarations of interest that specifically pertain to this meeting? Okay, there aren't. Thank you very much indeed. Moving on to the minutes of the meeting held on the 31st of January 2023. Are there any points of accuracy that anyone wants to raise? John Rush.
I just wanted to check on, it's on page 11 of the papers, but it's 8 of 19 for the actual minutes themselves. It says ICB running costs are expected to be around 2 million. I just think that's slightly underestimated. I wouldn't like it to go out in the public arena saying that that's what the ICB running costs are. So I don't know what that, I've maybe misinterpreted it, but that's what the old sentence says.
You're quite right, John. Should say there should be an underspend after that word.
Okay.
Yeah.
Right, that's okay, thank you. That's all I need to know.
Well, that's a helpful amendment to the minutes of the last meeting. Thank you very much for raising that, John. And then the action log. Are there any points anyone wants to comment on or question there? No? Okay, very good. Well, we're going to dwell a little bit longer on matters arising because there were two very important discussions at the last meeting. The first was on Dr. Bill Kirkup's presentation on standards in maternity care, and David Perdue in a moment, our executive director, chief nurse and of strategy and operations, is going to say something about that. And Jacqueline Myers also, director of strategy and operations. But before we do that, we're going to have just one more look at the examples of data that were assembled for us for the last meeting based on some questions that I put to the executive team. And Graham, our Director of Data and Digital, is at a family funeral today, so I'm going to run through those slides and make a few points which I think you'll find of interest. I'm going to move to the side so that and that you can still hear me. So if we have the first slide, I've got the pointer here, so this should all work well, let's hope. So just to remind you that I posed a range of questions ranging from diabetes to bowel cancer to health in socially and economically deprived areas, uptake of preventive health interventions, incapacity and frailty, level and nature of avoidable harm, risk to patients of acquiring a hospital infection, what do patients think about the care provided, children and young people's mental health, and progress on tobacco-related disease. So the idea of doing this was not necessarily to dwell on the specific areas, but to give us a feel of what the prospects were for us having data available to us on a routine basis at our meetings, which provide insight and help to guide decisions. And I think the conclusion was, after that first discussion, that we're not badly placed from that point of view. We have a very capable new team who are looking at this, and a very good range of data sources. So I think the answer to the question, yes, we're on track to start having more of our decisions informed by good data. So just because we looked at 3 specific illustrations last time, just to give you a bit of a feel for the granularity, I'm going to very quickly look at 3 more. And there were a number of questions posed about bowel cancer, and this was the outcome of the analysis. And I just thought there are some very interesting messages here, which are both specific to colorectal cancer, but also give us some general impressions of what it means when we start to look at the health of 3 million people, rather than, as in the past, looking at them through the lens of 8 separate clinical commissioning group organisations. So if you look at that slide, you can see that the incidence rate, which is the number of new cases of colorectal cancer in our ICS, is higher at 68.8 per 100,000 people than the national level. But also, if you look within the ICS at places, we've grouped the Tees Valley together because of small numbers, but you can see a very substantial variation there between Sunderland, which has the highest rate, and County Durham. Now, just to make a general point before moving on, that this sort of data is described in epidemiological terms as observational data or descriptive data. So it never gives you definitive answers to questions on its own. But as I say, it provides insights which give the opportunity for further exploration and investigation. And in some cases, when you do that further exploration, you find that there are anomalies in the data missing, failure to take account of differences between populations which are nothing to do with their disease risk. So we always need to bear in mind that these are not hard and fast conclusions, but they do show you the sorts of questions that we'll be returning to when we look at equity and inequalities in health in particular. Now, I put the bottom slide, part of the slide there, is also interesting because there's a lot of research evidence emerging across all developed countries of an increasing incidence of large bowel cancer in younger people. And you can see there we're also higher than the national average, and there is also a similar variation. So bowel cancer in younger people, for which there is currently not a screening program, is an issue of growing importance. Moving on quickly, very quickly, the stage of diagnosis is also important. Can you catch it early, with a better chance of survival? And you can see there across our places quite a variation there in the stage at which bowel cancer is detected, with South Tyneside appearing to show the best record on that. But of course we have to be careful, because if you look at the last column, there's missing data which may distort the comparisons. But again, some signals there of something that needs to be looked at as far as performance of services is concerned. This is another measure which in some ways is one of the easiest things in population health to address, which is the technical side, the preventive services, the screening, the childhood immunisation. So getting those things sorted out and performing well isn't as difficult as some of the other things that we have to do. And on immunisation, childhood immunisation, we have the best, if not one of the best performances in the country. Very, very good record on that. Now, there's a rather complicated schematic on the left. Just ignore that for the purposes of today. But the interesting chart, I think, is the left-hand column showing the proportion of people with high blood pressure whose blood pressure is controlled. And it so happens that we do a little bit better than the rest of the country on that, but still I think a concerning finding for the country as a whole, but also our ICS, showing that probably 2/3 to 3/4 of people with high blood pressure, that blood pressure isn't controlled, which puts them at risk of heart disease and stroke. So when we're trying to tackle those conditions, there's much we have to do in preventive terms, but getting the organisation of hypertension services right is clearly one of the easier things, which across the country is not being done very well at the moment. And then if we look at other metrics of preventive services, take the left-hand one, bowel cancer screening, a variation there in uptake. And then if you look at the right-hand graph, breast cancer screening, an even more marked variation. And if you just bear in mind that bowel cancer screening is a test sent through the post and returned, so it isn't an organised service in a facility or anything of that sort. The follow-up obviously is, but breast cancer screening is a different type of preventive service in that it is a service organised on the ground. So when you see a variation between the percentage of women in North Cumbria and North Tyneside like that, you want to know why. Now, we don't know the answer. It could be to do with health-seeking behaviour, but it could be to do with the organisation and effectiveness of services. This one is another one which of particular interest to me. These are the serious patient safety incidents that have been reported in the ICS area within provider organisations. And a couple of things come out of that, really. First of all, again, to show variation, some of that may be to do with different levels of reporting rather than different levels of risk. But it is a concern that we're still, and the rest of the country's no different to us, unfortunately, seeing some of the common causes of these, medication, very top of the list, rather surprisingly, actual suspected self-harm incidents. Not all of those will be in our mental health trusts. Some of them will be happening in the acute trusts. But common causes you will see across the country leading to serious untoward incidents. And then these are the never events. And again, you can see by digging a little bit below the surface some interesting insights into how these are occurring. They're rare in proportion to all the care that's provided, but even so, scope there for preventing and reducing risk, with quite a high proportion of them in the area of surgical procedures, errors, wrong site surgery, that sort of thing. And then finally, there are quite a few stats in the pack in your paper about children and young people's mental health, but this is obviously the area of greatest concern and something that we've been focusing on. And you can see there, again, potentially differences in the rate of occurrence in different parts of the ICS, which could benefit from some further exploration, and that's being done. The reason the other figures are in grey is that it's a principle of official data that once you get down to a number 5 or below, there is a risk that the individual might be identified, and therefore they won't give a precise number. But you can see there Tees Valley, County Durham, and to a lesser extent Northumberland areas where there will need to be a lot of work done about that. So that's just really, I think, to say a few granular observations, but really to make the point that we have good data. It doesn't give definitive answers to questions, but it opens the door to a lot of investigation and exploration, which over time, I think, will point us to ways in which we can improve health, reduce inequalities, and improve standards of care. As I said, I have exceeded the time a little bit for that item, but if there are any points or questions anyone wants to raise. David.
Liam, now you've identified by this exercise that there is data available, good data, on the areas that we want to look at. Do we think, and maybe this is a question for Sam, do we think that during next year, for example, we might start applying this data in the implementation of the strategy, deciding which ones we're actually going to go for, and doing an action plan, and et cetera, et cetera?
Yeah, absolutely. I think there's certainly, in terms of measuring outcomes, we certainly will do that. I do think the presentation that we'll receive from Neil this morning, particularly around looking at our Healthier and Fairer Advisory Group, be supportive. I think the other thing just to underline is this data, a lot of it is in use already, and I think particularly through our health and wellbeing boards across the integrated care systems, the system, and working with our directors of public health. I think the point, if I may, which is also a bit of a thread into and from the session that we had last board meeting with Dr. Bill Kirkup, is the point of curiosity. And I was really struck, Liam, about the final slide, data saves lives. I suppose it's about us being curious and using this data linked into our joint forward plan and our delivery plan, so that we're actually tracking the improvement of our outcomes. But it absolutely is already being used, and we will continue to utilise it.
Great. Thank you very much. Thanks.
Mike, you're one of our experts on data, so thoughts?
So the wonderful presentation, Salim, and I have a million questions and the specifics which I won't go into, but I guess that leads me to wonder, to what extent should we be looking at this at board level, and which bits can we add the most value by scrutinising, recognising that there's a huge amount of depth of data that we can go to, and go into that really granular level. While interesting, debating it at this level is not practical because there's just so much of it. At what point can we add value as a board by being appraised on it and scrutinising it?
Jacqueline, would you like to comment on that?
Thank you, Salim. As I've mentioned before, and we'll hear more about later, as well as developing a one-year operating plan, we're in the process of developing a 5-year delivery plan for the integrated care strategy that our Integrated Care Partnership Board approved back in December. And as part of that, we will be being specific about the metrics that we'll be using to measure success. The interventions will be agreeing to deliver our strategy. So what I would hope to see following the agreement of that 5-year plan is, I think, what Sam's termed a strategy deployment tool, where we can track regularly, but not perhaps as frequently as every board meeting, because some of these things take some time to move, whether the interventions that we're taking are moving us in the right direction in terms of outcomes. If I may just use a specific example, Salim, we do have a Cancer Alliance that's got a specific plan around trying to improve cancer outcomes and survival, and a key plank of that is about identifying cancers at an earlier stage, and screening programmes obviously a key part of that. So in our cancer plan, which will form part of our overall 5-year strategy delivery plan, we'll have some clear actions around increasing pickup of screening programmes, and in particular addressing them in communities where we've got low take-up at the moment. So you'll start to see, if you like, the thread through from, at the one hand, our very high-level goal to improve, have longer, healthier life expectancy and have fairer outcomes, so to see improvements for those communities who have the poorest life expectancy just now, and then some specific actions around, for example, improving cancer survival. Thanks.
And it's a very good question, and just before Eileen comes in, and I think it's probably something that we do need to reflect on, because I think there is probably a feeling that because we have an overall strategy and we'll have some headline metrics for measuring success on that it would feel like sidetracking to go away on this year. But part of me looks at the country's record on hypertension control and thinks it's a classic example of something where, looking at it through a system quality improvement lens, you might be able to save a lot of lives. And Annie's going to be talking later about our learning and improvement work. But I think we have to find a way of avoiding being accused of going into detail when we've got a strategy, because these are real people, real lives, and they're just the ones that happen to pick on for that presentation, but there will be other areas as well. So I think we need to keep this as a live debate, because I'd like to think that we we are looking at circumscribed issues which are life and death matters, as well as advancing the overall broad approach of the strategy. Eileen.
That one. Oh, just a comment. Certainly, when you get to the point of what do we know, and it points out the problems as you've eloquently shown us this morning, Liam, then we have to think about what will we do. And it really is looking at the information coming out of NHSE at the moment about embedding research in health and care systems. We really need to think about what are the kind of evidence-based approaches to try to address some of these issues. And that will mean stopping doing some things. So we need to consider where there's evidence to suggest where we should try new things, and also evidence to suggest that we might need to break patterns of established behaviour in order to make some headway on some of these challenges for the region. So it's really just a comment to say we need to look to our colleagues who are generating evidence, particularly around implementation science, etc., to establish what's the best way forward to address some of these particular issues in the region.
Kath.
Thank you. Yeah, just kind of building on what Eileen was just saying there. I was just having a quick flick through the data pack, and there's some really rich information available within that data pack. And I'm one of those people who really loves a bit of data. But actually, there's some particularly around the children and young people, as you would expect me to raise, the mental health issues, and actually down to the ward data, and how are we working with some of our service providers in those areas, and particularly schools, to support those schools where there are higher levels potentially of mental health referrals, and what does that mean for us as a system? Because as we know that we've seen a massive increase in the numbers of referrals around mental health for young people, and that is an area that we are struggling to help move further on and help our children and young people.
Thank you very much, Kath. David Thompson.
Thank you. As people have said, this is astonishingly data rich, but it does mention on page 25 of the introduction the recommendation actions required. That needs to be trusted by patients, service users and the public. And in terms of that, such data needs to be used in association with somehow, with the voice of the patient and so on, the voice of the wider public. So get the benefit of both. Not easy to do, but I think it needs to be balanced between what patients and service users and the general public are also saying about these issues, as well as this data rich to make things better for patients and to save lives.
I think the other thing to just mention from your perspective, David, is that those immunisation rates are partly because of the efficiency of services up here, very well organised, but they're partly also to do with solidarity of the communities who are coming together to protect others, because that's what immunisation does, and we know from some of the survey work that populations in this part of the country view the world like that, whereas others are more individualistic in the way that they approach decisions about vaccination and contributing to a programme like that. So I think there's an element there which we possibly could build on for the future. Sam.
Thank you, and thank you for raising that as well, David, because I think looking at data without the voice of people in it, I think it and sometimes doesn't allow us to see the full picture. And just to make the connection back to the point Kath raised as well, just in terms of working with schools, the solutions do often sit in our communities. So when we are looking at data, we definitely need to triangulate it to bring in the patient voice, the voice of our community leaders, our community and voluntary sector. And I think Eileen as well, before we get into solutionising, we really need to put evidence-based practice at the heart of that and drawing on our research skills. Just in terms of the point around screening, when I was looking through this, I was really struck by the differences. I was thinking, actually, what's going on in Cumbria? What are we looking at in North Tyneside with women and low uptake of breast screening? We need to get out and ask people, and actually they will, I think, on the whole, be able to tell us what the issues are. So I think it's a really good point in terms of when we're looking at data, the need to triangulate it with our clinicians and also our communities and people using the service.
Okay, well, thank you very much, and I'm sorry to have run over a little bit on the time on that, but a very interesting subject area. David Perdue, the other matter arising, which was to talk about the work that you're initiating to follow up on Bill Kirkup's presentation, and the issue I think that we wanted to pursue is to how we get early warning, not just for this group of services, but other services about potential serious problems in standards of care in different parts of the ICS.
Thank you, Sir Liam. So obviously it was a really powerful presentation that has been shared widely among colleagues, and there were 4 key areas for that. So one of those was monitoring safe performance, so finding signals amongst the noise. So specifically in terms of maternity care, but is across everywhere, is obviously that clinical audits of implementation of shared standards. So we look at the key standards that we need to do, and then from an ICB, it's a standardised tool we provided for assurance against a number of key clinical pathways, but specifically for maternities, the Saving Babies' Lives Care Bundle, which when we looked at our CNST returns from our 8 providers of maternity service, 4 of them hadn't achieved that. So we're doing some particular work around saving babies' lives. And then there's an ICB-wide dashboard to support benchmarking and improvement. So actually that we look at triangulation. So one of those is the metrics from regulators. So what is the Care Quality Commission saying? What is the feedback from the NHS England national programmes? But then the really important thing is actually what are our people saying? What are our patients saying? What are our carers saying? So it's exactly what we've just discussed. We have a set of metrics, but we have to triangulate that with what people are saying. And as part of that, we have got a lived experience strategy, the outputs of which will feed into our Quality and Safety Committee, so we can actually triangulate what is being said. And there's that big thing that Sam says around curiosity and how we get our leaders to be more curious into the services that we're providing. Then we've got standards of clinical behaviour, as though technical care is not enough. And what we've said is that we'll determine our overall success by listening to women, particularly in terms of maternity, and their families. So that's around leading implementation of a North East North Cumbria Equity and Equality Action Plan, including work across organisational boundaries. And then it's the commissioning and funding of our Maternity and Neonatal Voices Partnership to cover it so each trustee covered within the providers and reflecting the diversity of the local population. The next standard is around flawed teamwork and teams pulling in different directions. And so again, we'll determine the overall success of that by listening to our staff. So all staff working and overseeing maternity and neonatal services and other services are supported to work with kindness, compassion and respect. So there's a big area around psychological safety and that people feel safe to voice their thoughts and are open to constructive challenge. And some of this is the learning that we've got through the closed cultures work, which was identified following the Edenfield programme and Panorama. So there's been some great work done with both our mental health organisations, but we need to share that and stop that closed culture and that things are just internalised and it's okay when it's actually not okay. So we need to ensure that people receive constructive appraisals which support their development, and we work, learn and train together as a multidisciplinary team across maternity and neonatal care. And again, when we looked at CNST, 3 of our organisations again had not achieved that in terms of that training. So as an LM&S, our job and our support to those providers is to look at how we can deliver training more effectively. And the big important bit for me is that a team can escalate concerns supported by a conflict of clinical opinion policy in case of disagreement between healthcare professionals. So one of the big things when you've got independent practitioners is kind of that ability that people can have that conflict and actually get the best outcome for our women. And so as part of that, we've just launched our ICB Freedom to Speak Up strategy, which we can bring to other board if people are interested, to ensure that people have got that pathway where they can speak and their concerns be taken constructively. And then one of the big things is organisational behaviour, so looking good when doing badly. So we need to ensure there's a shared commitment to safety and improvement at all levels, and the focus is given to how things are implemented, not just what is implemented. We need to use the data to compare outcomes to similar systems and understand any variation and where improvements need to be made to support and get that oversight. And part of our offer in terms of areas where people are struggling is how we support those, and we support resources channeled into places that need them most. So on the 10th of May, we've got our ICB planning event to look at actually our maternity and neonatal services going forward, which we're delighted to say that Bill Kirkup is coming to. But there are 4 key areas where we're going to look at, and one of those is listening to and working with women and families with compassion, growing, retaining and supporting our workforce, developing and sustaining a culture of safety, learning and support, and then standards and structures that underpin safer, more personalised and more equitable care. Thank you.
Thank you, David. Well, you'll be hearing more about this as the work develops, but it's a very important thing and something that I know that our Chief Executive is particularly passionate about. And I think important to recognise that if problems are identified early, then the action's likely to be learning as well as protecting future patients from harm. If the problems are identified late, the action, unfortunately, will usually be judgmental, and many patients will have been harmed that could have been avoided that harm. So there's a great importance to being able to get this surveillance in place and understand what's happening. Okay, anybody? Oh, yes, sorry. Yes, go ahead, Rajesh.
Thanks, David. Some real good stuff there, very specifically about maternity services. But many of those aspects or principles could apply to many other services, isn't it? So my question was, what is the plan about taking some of those high-level quality and safety sort of thinking and ensuring that our new arrangements of monitoring quality and safety through the patient safety incident response framework, which is the new framework which will come through, is kind of embedded. So what I would not like is that every service to be doing this when there are some clear themes across the board which people can adhere to. So any thoughts on that?
Yeah, so that's a part of our quality and safety strategy as an organisation. So obviously PSAF, Patient Safety Incident Framework, launches in September, and we've got some early learning from Durham particularly, who's been an early adopter, to ensure that we follow that process. And the important thing for me around the new channels is obviously that people don't misunderstand what it means. So it doesn't mean that you don't report SIs, it just means there's a different way of investigation. And I think that's a really key thing, but obviously it forms part of our quality strategy for the ICB.
Thanks.
John Rush?
Just wanted to check, because we talk about ICB, we talk about it as a board, and yet a lot of these things are being picked up, obviously, by the trusts who are delivering the service. So just a couple of questions. The 10th of May, I take it that's an event for all the maternity units. Working with, so we're playing a facilitative role there within all of that. But I was just having a quick word again. I just wanted to try and work out from a provider's perspective that they're hands-on directly. It's their staff that are dealing with these ladies and the birth of babies. What is it that you've had to put in place? Because you've had to put a lot of things in place, Ken, as foundation trusts to be able to do this, which is not just led by the ICB, it's led through the trust as well. So I think it's important to know what goes on in a trust, I suppose. Is that a fair question?
It's a fair question. It's quite difficult to answer in a succinct way. I mean, we've had a number of issues around maternity, as you know, with Ockenden, East Kent. We still haven't yet had the national, let's pull it all together, publication. Thursday. That will give us all the consolidated action that the NHS is expected to put into place. Not all of which is about providers. You've heard this morning from David about things like the Voices Partnership, for example, as well. So, but a lot of it's focused on organisations. A lot of it revolves around staffing, and a lot of it revolves around culture. So I think you'll find that organisations particularly have been focusing on those two things, not in isolation, because those are things first, I think. We can do something about hopefully staffing, and we can do something hopefully about delving a bit deeper into the culture and our clinical teams. And it's a great point that Ragesh makes. This isn't just about culture and our maternity teams, it's about the culture across all our clinical and operational teams and organisations. That's a much bigger and longer piece of work.
Thanks, Ken.
Thank you, Chair. Just on your point, John, I think from an ICB perspective, I think we have an opportunity to convene the whole system here. And I think Rajesh's point is very well made. And it was what Bill Kirkup specifically talked to us about when we did a system-wide learning event following our last board meeting, not just across health, but also we involved our local authority colleagues in this as well, which is the impact of culture and the effectiveness of team working. These are issues that pertain in all of our services and our risks. So there is something about our ability as an ICB both to convene colleagues to learn, but we do, as David has set out, have a very specific role around the local maternity network, and also in terms of overseeing and supporting our providers, particularly with the improvements they're making and also how we're learning. But we're very much doing that together as a whole system.
And when we were discussing this a couple of months ago, we recognise, I think, that the culture applies to the whole organisation, but also within the organisation. You could have a serious adverse culture in the night shift, and if you haven't got the right leadership in the organisation as a whole, then that wouldn't be detected. So openness, understanding the organisation, not just in a superficial way, but quite deeply, is very, very important. Final point then, Jacqueline, and then we need to move on.
Thank you, Salim. I just wanted to make the link to the Integrated Care Board's oversight framework, which we saw here in the November board meeting. And we're working very closely as an exec team across all domains to make sure that we have a rounded conversation with our providers. And so as David is sort of deepening and broadening the range of quality, patient and staff information that's coming through, we're drawing that through into our oversight framework. So we're not just having a conversation about the finances and the headline performance metrics, but also about the individual markers in the staff survey that came out recently, for example, or the themes that are coming through from the range of incidents and other reporting. So we've got a formal way of pulling all of the informal and convening work that's going on into a conversation at an exec-to-exec level with each of our key providers.
Thank you. Sorry, Eileen, the light's not great down at that end, so I can see your flag.
Thanks, Chair. I just really wanted to point to a reflection we had at the Quality and Safety Committee led by Vice Chair Hannah Bowes, where we really thought about the Bill Kirkup presentation. I think one thing that struck me that Hannah contributed was that a lot of people don't complain. They're so relieved to get home with their baby, and they deal with some of the trauma that can be associated around birth, for quite a long time after. So I really would recommend that we think about reaching beyond just the system, the providers, the trusts. We think about our communities and people who have had difficult experiences. They've not been heard, they've not been fully respected. They've gone home and they're just trying to get on with dealing with a young child and whatever. But really, really need to think beyond just our formal care providers, because many people, may have a subsequent child, may decide not to, and we really need to find a way of listening to people who are not currently in contact with health and care services.
Okay, thank you. Moving on then, Sam, Chief Executive's report.
Thank you, Chair. I want to start, this item isn't covered in my report because the publication of the report followed the publication of the board reports. I want to start, Chair, by acknowledging the publication of the independent report into Tees Esk and Wear Valley services following the very sad deaths of Christy, Nadia and Emily. This is a second report that was undertaken that's more of a system-wide review, looking at the governance, the leadership and also the holistic and integrated models of care available. I think also incredibly pertinent to the conversations we've already had this morning is the importance of listening to families and also patients. That absolutely is a huge thread that runs throughout the report. quite often we know, and usually it's in the aftermath of such incidents, that people can tell us what's going on in services and also can point to the risks. So the points that have been made, particularly around listening to the voice of our patients, our communities and our families, is incredibly well made. There are some actions contained in that report for us as an integrated care board. That report will be reviewed regularly through our committee structure of the ICB. And Chair, I would propose that we bring back progress with the recommendations, the actions of that report in the next 6 months to this board. I do want to mention, and it is covered in my report, the requirement that NHS England has made of each of the 42 integrated care boards to reduce our running costs by a total of 30% by 25-26 and 20% of that 30% by the end of this financial year. I have established a working group within the Integrated Care Board that has already established some success measures for the programme, where we'll have to see a reduction of some £14 million in our running costs, which is no small number. Having said that, we are seeing this as an opportunity as an Integrated Care Board in terms of progressing how we operate as an Integrated Care Board and how we are able to support the 4 core aims of Integrated Care Boards and the delivery of our strategy, Better Health and Wellbeing for All. And then finally, I just want to mention, and is again covered in the report, the nomination, but also the appointment of our 4 integrated area ICP members, each elected members from our areas, and those area ICPs are underway with the meeting in the North having met now. Thank you, Chair. Happy to take questions.
Comments and questions then? David.
Thank you, and thank you for your report, Sam. Just a reference to section 3.2, place-based working. Can you confirm that each place will be empowered from April the 1st to undertake the responsibilities in terms of delegated finance actions and so on? Can they start then, or will it be more progressive?
Yes, I can confirm. Place boards, they're empowered with the individuals with delegated authority, David. However, we do need to recognise that over the months ahead there'll be further development. So areas like Better Care Funds, Section 75 agreements are all delegated, and decisions can be taken at place. Where we have larger arrangements with our NHS providers, we will be holding those centrally with Integrated Care Board. So the delegation of place will be incremental over the months ahead, but they will be able to take decisions at place.
Thank you.
Jacqueline, your flags from, Mike.
Just with regard to the running cost reduction, 30% is a big drop, and the NHS, based on national data, it certainly looks like it operates very leanly already. At some point, there is the risk that that becomes less of an opportunity and more of a genuine risk as we start removing things that are actually useful, rather than things that are just improving productivity. I guess if that point comes around, will we be appraised as a board as to the point that we say we've reached, say, 15% reduction, and now we recognise anything further is going to be have potential harmful consequences?
Yeah, absolutely. So we're in the process at the moment where we've been undertaking a full review of the technical ask of the running cost reduction and designing the programme which will oversee delivery of that and the success measures. And be very happy, that's a 6-week piece of work. Be very happy to appraise the board fully following that piece of work. I'm not yet clear at the moment what that may well mean in terms of a headcount reduction. We have put some immediate measures in place where we've restricted recruitment to the ICB with the exception of roles that are statutory responsibility or would impact on quality and safety. So we're mitigating some of that risk. So what I'll do is once we've concluded that piece of work, bring that back. I would say though, I think probably one of the more significant risks will be what I call organisational paralysis. Clearly this is a time of concern for staff working in the Integrated Care Board. We have already put our several hundred staff through some quite significant change over recent months, not least our most recent change, which is the implementation of our multi-professional clinical leadership structure. So us being very clear about what this means for individuals as soon as we possibly can, and having clear and open, transparent communication with the organisation to mitigate that risk of organisational paralysis with what's already going to be a very challenging, busy year that's bringing us lots of opportunities will be really key, Mike, but we'll bring that paper back through the board for your information.
John Rush.
Just wanted a bit of a positive as well in terms of your report, actually, Sam, and it's the bit around the criteria to reside discussions that took place between local authority representatives and ourselves. And I have to say, knowing and having lived through some of this in North Cumbria, how difficult this has been, and yet we're seeing there some reductions in terms of the numbers, and we're seen as an area actually to learn from, which again I think from a partnership perspective is massively important, and I wouldn't want to underemphasise that because I think it's really good. So I want to place credit to people involved in all of that. And then secondly, I just wanted to talk about the learning disability transformation because it is an issue. I just wanted to check with you, David. Are we talking about here how we're going to manage the number of people who are inpatients, that we're trying to put them into the community in a better environment? That's the issue we're talking about when you talk about there, because right, and I know there's ongoing work with that, and I know, Rajesh, we've talked about this as well at the Finance and Performance. It is a big issue for us, and not one to be underestimated. Yeah, so it was just I wanted to sort of do the positive first, I have to say, on that.
Yeah, I think it's a significant achievement that we were one of the integrated care systems that were identified by the Department of Health and Social Care to come and learn from around our reduction in the number of people in hospital who are ready to go home. And I also think this will link to the presentation that Annie will give in terms of how we're utilising our learning and improvement community across the system. Having said that, I do want to commend David's leadership, but also all of our directors of adult social care in our local authorities. I think one of the real opportunities that we saw was the delegation to place of how that national funding was to be utilised, because our partners in social care know the market better. They know what it's going to take in terms of both preventing admission and also supporting people to leave hospital. And I think that's been a very collaborative and supportive approach to this particular issue, which is an ongoing issue which we continue to have to work hard at.
Thank you, and thank you for the report. We move on now to item 7.2, which is to hear progress on the initiative to set up a learning and improvement system, and Executive Director of People, Annie Laverty, is going to give us a presentation on that.
Thanks, Chair. Prior to the formation of the ICB in July, 40 senior leaders across the system were interviewed, and developing a learning and improving system was identified as one of 8 key priority areas for the integrated system. So I'm really delighted to be able to provide you with an opportunity of where we've got to in the development of our own learning and improvement community for the North East and North Cumbria. The development of a learning community is a critical part of our integrated care system and strategy. We want to be able to tackle some of our biggest challenges with a learning and improvement mindset. And importantly, we also want to build on a long and proud history of improvement within our system and build on existing strengths and learning and sharing together. So I wanted to make early reference in my presentation to some wise words of senior leaders, really thought leaders in quality improvements, giants, if you like. I believe they link well into the work that we wish to do. The first quote is from Deming. Deming is universally acclaimed as one of the founding fathers of total quality management. He is sometimes attributed to some of the Japanese manufacturing success in the 70s and 80s, largely attributed to the thinking of Deming. And what he reminds us about in this quote is if we want to do better, then it's worth identifying and indeed improving the deficiencies that exist in our systems and our processes, rather than putting undue pressure and unreasonable pressure on our people. And the second quote is from Don Berwick. Don Berwick, the founding chief executive of the Institute for Healthcare Improvement. Don has served on the Faculty of Medicine at Harvard and at Harvard School of Public Health. And Don reminds us that we will find the will to be better at all parts of our system. But it is our responsibility as senior leaders to unleash that potential. So I wanted to reference the fact that our work around developing an improvement in learning community is coming at a really important time, I think, for improvement in the NHS. The Improvement Hub on the NHSE website brings together a wealth of information, improvement knowledge, information, guidance with toolkits from right across health and care, which we'll be keen to utilise. But in the middle of next month, Amanda Pritchard will be launching a new national improvement strategy at a meeting of all NHS chief executives. And this follows a review that has been undertaken by NHS England, a review that was led by Anne Eden, which is looking at the way that the NHS delivers effectively on current priorities. And one of the recommendations from that review is that the NHS and provider and systems adopt a standard approach to improvement that is based on best available evidence. So I think our work is coming at a really good time. I'm delighted that we've also made a really important start on that work and what that might mean as we grow our own system for our own communities. There are, in fact, a number of approaches to quality improvement in different schools of thought, really, and this slide highlights just some of them for you. So they vary mainly according to their emphasis and focus. So, for example, if I were a Six Sigma black belt, I might have particular expertise in focusing on eradicating variation. Whereas if I was more inclined to a lean school of thought, I would be focusing on adding value and how do we reduce waste. Plenty of examples of bottlenecks sometimes in our systems. So a theory of constraints is an approach that can sometimes be utilised because the focus is on flow. Experience-based co-design is slightly different from the other methodologies in that they don't tend to have a focus on processes systems, but actually their focus is more around elevating the experiences of people experiencing a service and that why they use ethnography as a key tool to understand those experiences a little bit better. I think what I wanted to say about, regardless of the approach that you use and the particular emphasis, the fact is these approaches all have far more in common than they do differences that divide them, really. And I've put some of those commonalities there on the screen for you to see. I think really important as boards that we focus on these key principles in terms of the approach. The evidence suggests that it doesn't matter which approach that you use particularly, but actually once you have selected your approach, making sure there is a consistent application is important so that you don't overwhelm staff in that process. There are also a great number of different quality improvement tools, and improvers might choose to apply different tools at different stages of their process according to where they might add value. So if we were identifying a quality issue, for example, what better place to start than from listening to the views of our communities, our citizens, service users, and patients and families. If we were developing a strategy or considering a number of options or change ideas, we might use force field analysis to help us select the right approach. And if we're in the process of our improvement program of testing a number of different options, we certainly want to be able to, statistical process control is a great tool to enable us to understand what change is taking place that can be directly associated with that intervention, distinguishing normal variation from change that is likely to have happened anyway, from change that actually has a special cause. So part of the commitment of our learning and improvement community is to develop improvement capability across our system and confidence in using different tools for the right reasons at the right time. And as I mentioned, we have a very, very proud history, a long history in the North East and North Cumbria and tradition of a commitment to learning and improvement. At a strategic, from a strategic direction point of view at a regional level, including a really early focus on health inequalities, seminal work, and a strategy led by Salim. And then the North East Transformation System in 2008, the Strategic Health Authority, which led very heavily on Toyota thinking and establishing lean practices across the North East as part of the North East Transformation System. And we have the benefit of local providers too, who also have a long history and established processes and orchestrated programs of work to improve the quality and safety of clinical care. So we were extremely lucky with that history. And we also incredibly lucky that much of the current thinking around learning systems is taking place locally. We've got fantastic academic expertise in this area. And the current thinking is helping us understand learning health systems, what they are, how do we develop them, and how do we evaluate them too. So this framework is an example of one of those, published by Tom Foley and Luke Vale just last year. And Tom's been a visitor in the health economics team at Newcastle University since 2010. He's a child and adolescent psychiatrist, but he's also senior clinical lead for data at NHS Digital. And I think in Sir Liam's presentation this morning, we see that link between that understanding of high quality data as a key asset in our learning systems, and a fantastic example of that this morning. So in November of last year, I applied for additional resources to scale innovating for improvement work funded by the Health Foundation that had originated in Northumbria Healthcare. So that award of 250,000 will enable us to do a number of things, but most importantly, to work in collaboration with local academic partners to really evaluate and understand our learning and improvement community in its first year of development. Many definitions of learning health system exist, but if you'll bear with me, I don't often read from a slide, but I think this is a particularly powerful quote. Learning systems outline a way of making social action and public service more responsible to the bespoke needs of each person that it serves. Creates an environment in which performance management is driven by continuous learning and adaptation. It fosters in leaders a sense of responsibility for looking after the health of the systems. And it is these systems which create positive outcomes in people's lives. So I think it encapsulates beautifully that quote, the complex work that we wish to do together. We know that learning systems can differ in terms of their size and their ambition. They could be place-based, and if so, they could exist across a range of geographies. So it might be based around a team or individual provider organisation. It might reflect the work of a health economy, or indeed a whole nation or care service. These learning systems could be condition-based, so it could be about improving the services for people with cystic fibrosis, for example. Or they could be thematic. It might be about improving procurement, it might be about adopting a particular technology, or indeed improving ambulance handovers. Or they could be a combination of those things. It might be focused on improving access to mental health services for younger people in Carlisle, for example. We launched our own learning and community on a very inspiring and special day on the 21st of September of last year. And at the start of that day, we listened to 2 testimony films. The first was learning from the experiences of a bereaved mother who lost her 17-year-old son, Samuel, to suicide. And Samuel's inquest is ongoing at the moment. And we listened to a recorded clip from the BBC series on ambulance services. And in that, a story about deprivation and an urgent need to address chronic and complex health and social care needs. So within that, I think an illustration of our true north, the link of our improvement work to our strategy, and great stories that have real power behind them because of their authenticity, the fact that they're clear and relatable. Because many stories, particularly those relating to loss or harm, come at a price to the story holder. And in listening to those, honouring those stories involves not just listening to them, but actually hearing those stories and acting and improving as a result. So 180 people came together at that inaugural event for an inspiring day. Our commitment on that day was to be the best at getting better and to ground our work in work that was highly relevant and practical, based around the challenges that we were experiencing and how do we address those most pressing challenges in a way that drives change fastest. So in a democracy exercise, participants came together and identified these 7 key priority areas for the learning and improvement system to take forward past that event. The event attracted a lot of attention on social media, and the energy and commitment certainly from all was very, very evident in the sentiment score. People felt deeply positive about the event and committed to getting involved in improvement and change. An ambition to be the best at getting better means understanding what best means globally as well as locally, and aspiring to worldwide best practice. So we seek to bring international partners into each of our learning and improvement events. And at our discharge event at the beginning of March, we had examples from America and from Sweden, best practice linking into our breakout sessions. Children's Cincinnati Hospital, widely regarded as a highly innovative system for children healthcare in the US, has already agreed to participate in our forthcoming Children and Young People's Mental Health Summit. And Helen Bevan, deeply connected to all parts of a global quality improvement community. Helen's just been appointed as chair to a position in practice and healthcare improvement at Warwick University, and has been helping us providing expertise and guidance since the summer of last year. We also want to learn from practices that have attempted to scale best practice, best international practice, and amend and adapt for the UK. So this infographic that you see on the slides highlights the evaluation of a partnership with the Virginia Mason Institute. And this evaluation examined how 5 NHS trusts have attempted to build a culture of continuous improvement. and the lessons that it has for us about how we plan and implement an organisational-wide approach to improvement. So there's probably 3 points that I want to raise about this slide, really. And the first is that the evaluation shows that a really strong culture of peer learning and knowledge sharing is absolutely critical enabler of organisational-wide success. So organisations that had the highest CQC ratings had much greater levels of social connectedness within their organisations than organisations with the lowest ratings. And that evaluation suggests that organisations should really prioritise efforts that allow staff to come together on a regular basis in environments that feel safe to share ideas and learn in an open and respectful way. The second key lesson is about highly visible and sustained commitment to improvement programs from senior leaders in organisations. And this is essential if we're going to get organisational-wide traction around improvement. Because without that commitment from senior leaders, there's a risk that we will see improvement along specific pathways, perhaps, or in particular services, but we won't see the organisational and generate organisational benefits. And the final really critical point, and we've referenced it a number of times today, around our true north, is the rule of the golden thread, really. So evaluation highlights the importance of ensuring that improvement priorities and metrics are fully aligned to organisational strategies. And this helps to ensure that leaders, managers, improvement teams, community groups, partners are all aligned and shared and behind a common goal, really, a shared purpose that we know makes the difference and allows far more progress to be made at a shorter pace and time. So we're able to apply that really valuable learning to the events that we've convened to date. And we held a very successful one, a recent summit on safe and effective and timely discharge on March the 9th. We had a fantastic response to that event. More than 220 attendees joined us. And the quality of breakout rooms on the day was truly impressive. We had learning from local, regional, national and international teams. And delegates spoke about the very difficult choice they had of selecting just one breakout room. And we've learned from that feedback. And we're going to be able to make the materials available across the learning and improvement community. And we will build on that event critically to develop an improvement collaborative for safe transfer out of hospital. It has been identified as a key priority in September. And critically, it allows us to make that connection, I think, between quality improvement work and delivery. And here's an example of a QI tool that we might use. It's an example of a driver diagram. I'm not sure if everybody's familiar with diagrams. But what it allows us to do is make sense of the reasons behind delayed discharge and where we might focus our improvement efforts. And finally, I just wanted to conclude by talking about the power of our communities. One of the reasons, as a people person, that I'm so drawn to this work is because it's going to take all of our people to be successful. And this slide, a fantastic example of social care research and a lovely representation of work that was funded by Skills for Care. And it was a study of unearthing all the skills, the talents, the hobbies, and the interests that exist in our communities. And if I focus on just one corner of that busy slide for you, I am reminded of the importance of an asset-based approach. We would be able to draw on the wide-ranging talent, skills, that exist to support learning in our communities, providing we take the time to discover them. So I'm going to finish there, Chair, if I may, but leave you with a quote on quality and what it takes to deliver it. Thanks very much.
Well, thank you, Annie. It's a an excellent presentation, giving us a very clear picture of the aspiration that this initiative has and some of the things that are starting to be achieved already. So I'll open it up to comments and questions. John.
Just in terms of resources, you've got to do all of this and how it can come together. And that's one question. And then the other one is in terms of that partnership involvement, which you've touched on, how does that get linked in as well, and how responsive are partners to it as well?
Okay, thanks, John. So really helped early on. We received approval through Exec Committee, £350,000 of ICB funding to support us in our first year of implementation, and the £250,000 that we've had from the Health Foundation, we've been able to add into that. It's helping us make a really good start. It's allowing us to convene events. It will support a really proactive comms and engagement strategy, as well as have some data analyst time and project management time just around the infrastructure. So really delighted with that. I think the partnership around evaluation, it's given us a freedom to do that too, and I think that's really important. We want some early answers around the impact of this work. We've established, from a governance perspective, we've established a steering group that are due to meet twice monthly, bi-monthly, and that's really representative in terms of the partnerships that are part of that steering group. We've, to date, treated each event in its own right and a themed event in its own right, and the response that we've had from partners has been amazing around both the community engagement, third sector involvement, local authority partnerships around that table. And at each event, we've monitored and tracked that representation so that we can see where we need to do more. So, for example, at the discharge event, we could have had more representation from patients and primary care. It was obvious, and that is vital learning that takes us through to the new event. So really encouraged by that and by the response. There's a huge appetite for this kind of work.
Just one quick one is,
yeah.
So I was familiar with this approach, Cumbria Learning Improvement Collaboratives.
Absolutely.
I take it, so I can get it in my head, we're talking something similar, or we're talking a slightly different model?
No, it's very similar, and the CLIC team, a fantastic team, and colleagues that we will be able to draw on their skills and expertise. They've been doing this for the last 9 years. It'll become part of one learning and improvement community, John. We can't have competing ones, so it'll be the Northeast. It is the Northeast and North Cumbria Learning and Improvement Community, and that CLIC team linking into my team going forward.
David Thompson.
Thank you. Thanks for the presentation and for the work to establish this community. You mentioned in your presentation the importance of providing a safe, unfettered, secure environment where staff can feel free to talk, discuss, debate and so on. But might it be even better served if there were some representatives from patients, service users and so on? Or do you want to restrict this solely to staff so they can feel free to discuss and debate?
I was reflecting on the learning from the evaluation there, David. I think not separating those two things. I think as a community, a learning and improvement community, we will learn best where the voice of staff is strong and matched by the voice of patients and families in that. Both bring vital but different perspectives into that improvement work, and we're keen to embrace that. So it's important we've had patient and family representatives at each of those events that we've run, and link their involvement and engagement into the improvement work. So,
Sam.
Thank you, Liam, and Annie. Thank you for that presentation. Sorry, my button's not working. Get there.
Mine was doing that.
Thank you for that presentation as well. Just in terms of the learning and improvement community, so we've now got over 600 members, which is fantastic across North East North Cumbria. I attended the Discharge Summit, and one of the most enlightening, I guess, things that came out of that for me was listening to, and it was a number of colleagues who I would consider in frontline roles. I'd probably say about 80% of the membership of that summit were colleagues in frontline roles, and from social care, acute hospitals, mental health, was their renaming of the word discharge. They said actually was a real barrier, and they wanted it to be known as safe transfers of care between services. So it brought in all the issues around roles, responsibilities and communication. It was just such a good example for me of actually, again, the solutions and the opportunities for improvement don't all sit in this room and around this table. 99% of them actually sit out there in our services. And I suppose for us, this has to be, it absolutely needs to be aligned into delivery of our strategy, but also it's a mindset. I think it's an improvement mindset. So I think for us as an integrated care board, you can have an approach to managing performance, which could be punitive, authoritative, directional, or we work in partnership with our providers, our communities, in order to improve. And I think the mindset of being the best at getting better, I think is a good one, because there is always room for an improvement. And sometimes the answers aren't straightforward. We need to work at that. And I think the point around providing a safe space where culturally we can take an improvement approach is, we're not using performance data just to judge. We're using it to be curious, to seek to improve. So, Chair, I really just wanted to make the point about this is not an initiative. This is a mindset, a philosophy, an approach that we want to run through out the way we do things. And we've got a really unique opportunity here in the North East North Cumbria, because our partners told us, actually, if you're down on Teesside, or you're in North Tyneside, or you're over in the west of Cumbria, somebody must have done something before they've got the solution. We've got that opportunity to convene and connect people together so that they can share their learning, but also we can take that improvement mindset to be the best at getting better.
Now, that's an interesting observation. Here's a soundbite. First at being second. So we'd like to be first at recognising good things and latching onto them quickly. David Stout was next, I think.
Yeah, thank you very much, Liam. Great presentation, Ali. Really crucial topic. Yeah. You mentioned Amanda Pritchard will be launching a sort of standardised approach, I think, to improvement. Do you have any concerns about that? Do you think that might necessarily change the way we do things locally, or do you think it'll just create a catalyst and renewed enthusiasm to do it locally?
Yeah, not concerned at all.
Right.
So a lot of it will be based on best practice, and I think we're quite orientated to that as well. I think we'll see that our approach is very well aligned with what gets described nationally. So feeling encouraged about following on from the improvement review about the commitment to development and capability development, skill capability development, and a focus on improvement and what it brings. So now I think see it as an opportunity.
Great.
I think we shouldn't deflect from our own ambition of what we want that to represent and look like for the North East and North Cumbria, but I don't think they're conflicting.
Yeah. Can I, second question. How do we ensure that all the boards of the provider organisations out there are appropriately up to speed on this particular topic? I don't know whether it's via systems oversight or whether it's by your network, but just to ensure that the boards are cited on this. I just leave that with you, really, how to do that.
I think part of that new strategy will be recommendations about the development of boards, particularly in relation to quality improvement. Sam, I don't know if you want to add any more. You were...
Yeah, I mean, just in terms of the NHS boards, I mean, I think we need to be looking at all of the providers. just in terms of something similar to what we did after our last board meeting, where we give colleagues the opportunity to come together to hear about the progress. We have had some very senior leaders at the launch event in September, but I think we need to go back and revisit that. And I think particularly given Annie's slide around the what the evidence tells us, where this is most successful, which is obviously getting those senior leaders on board. So I think a combination of bespoke events, but also briefings, David.
Okay, we need to move on, but thanks again, Annie, for the presentation, and thank you all for the comments and questions, and we'll keep you well up to speed with all of this as it's happening. Our next item, before we have our break, I think it probably will be before we have our break, is the Director of Health, Equity and Inclusion, Hamid Matraghi, who is going to take us through a progress report on his work.
Thank you, Chair. Morning, everyone. Thanks for having me to the board. I'm here to talk about the work on health, equity and inclusion we're undertaking within the ICB. As you can see on the slide, which I'll put on in a second, sorry. My name is Hamid Matraghi, so I'm the Director of Health, Equity and Inclusion at the ICB. I'm really delighted to be part of the organisation, and I believe I'm the only Director of Health, Equity and Inclusion in any ICB. So we're really taking a lead in North East North Cumbria and kind of setting the direction and agenda. I think we should really be really proud of that. It links very closely with the work with Annie, who happens to be my boss as well. So what I'm going to do is I'm going to take you through a few slides, if that's okay. I'll talk you through kind of what is equity, diversity and inclusion. I'll take you through some of the kind of legalities behind it and what it means for us as an ICB. I'll take you through some of the data, and then I'll take you through what we're actually doing right now. So what I've been working on since I joined in December is an interim EDI strategy for the ICB. So it's going to represent a 1-year strategy, and within that year we will then build a 5-year strategy looking across the system. So a lot of what I'll be talking about is what is kind of coming up next and why we're doing this. So the first slide here, hopefully this sort of paints a good picture of the difference between equality and equity. So previously we've talked a lot about equality and what that means, but the difference between equality and equity is actually providing people with the tools, the opportunities for them to reach that board, which you can see on the right-hand side. So giving the person who's a wheelchair user the equipment that they need is crucial, but also giving that young person there the leg up they need in life to do that too. So that's probably the easiest way to describe equity in that respect. We're also looking at what is diversity. So this is what your workforce looks like. So really understanding the differences that those people bring to the table, the experience, their lived experience, and why we should value that. And hopefully that picture is representative of what a diverse organisation would look like. And then on the next slide, this is actually what does inclusion look like? So it kind of goes back to what Annie was talking about welcoming people to the organisation, hearing their voice, giving them the opportunity to speak up, allowing them to challenge, allowing them to do things in a different way, and kind of looking at things from a different perspective. So that's what inclusion is. So they're distinctly different domains, but they're all interlinked. So but they're not the same. And the reason why this is important from a moral, clearly from a moral and ethical case, if you look at it from an NHS perspective, we're here to provide fair and equal access to all. That's what we're all here to do. So really, this is at the heart of what the NHS is. Moving on, though, we do have some legislation behind it, as everything in life. So you're probably all familiar with the Equality Act. So the Equality Act is quite old now. It's over 10 years old. It's certainly, doing really good work out there. And people are picking up and understanding the Equality Act better. It does talk about its purpose to protect service users and staff from direct discrimination, indirect discrimination, harassment and victimisation. So, I think we all probably know what that looks like, but there is ways that you can do it through unintended consequences, moving services or providing things in different ways. So we should be cognizant of those things. And it brings together over 100 bits of different legislation. So it's a really strong, robust piece of legislation that's out there. You probably are aware of the protected characteristics it talks about, and I just want to call those out on the screen there. I'm not going to run through them all, but there's probably some there that you are very familiar with, and you will have many yourself, and there's some that you're less familiar with. So I'll just read them out just for ease, because I know it's a nice picture, but it's a bit hard to read. So age, disability, gender reassignment, marriage and civil partnership, pregnancy and maternity, race and ethnicity, race or belief, religion or belief, sex and sexual orientation. So those are the 9 protected characteristics. But one thing I'm clear to point out here, whilst they are the legal 9 protected characteristics, what we want to do with the organisation is go beyond the 9 protected characteristics and look at other things like caring responsibility, flexible working, menopause, and others. And obviously, depending on what the data tells us in our ICB, but across our system, we will align and take targeted action in those areas. So the body that actually oversees the Equality Act is the EHRC, or Equality and Human Rights Commission. They're the regulator, and they have powers to issue compliance notices, and actually they have been taking quite a lot of action against organisations fairly recently, and they can apply to the courts to turn that into compliance. And the EHRC actually wrote to Sam and Liam recently to remind them of the responsibilities of the ICB in the delivery of the Equality Act. I'll just mention in particular, though, they were interested in the public sector equality duty, which applies to all public bodies above and beyond the day-to-day Equality Act. So there are 3 limbs within the Equality Act we need to be cognizant of, in particular, to eliminate discrimination, advance equality of opportunity, and to foster good relations between different people when carrying out their activities. And that equally applies to our colleagues in the health and social care sector, as well as local authorities. And actually, local authorities have their own additional kind of guidelines in relation to PSED, public sector equality duty, as well. So it's really important that we get this right, not only for our people who work within the health and social care system, but also our patients and service users and their families. The next slide just talks about the specific responsibilities that the ICB has to fulfill itself. So the EHRC advises that we, as a board, set the direction and review performance and ensure good governance of the organisation. There's lots of different ways that we can do that, which I'm happy to talk about a bit later on. But also the recent Messenger review, which you'll be familiar with, talks in particular about the need for a step change in the principles of EDI and embedded in personal responsibilities of every leader and every staff member. So it's got to really run from the top to the bottom, or to the bottom of the top, if you want to look at it that way, and be that golden thread that runs through the work that we do at every different facet. And it also talks about the widespread evidence of considerable inequity in experience and opportunity for those with protected characteristics. And in particular, they call out race and disability, which is interesting because the NHS has the Workplace Race Equality Standard and the Workplace Disability Equality Standards. And those are 2 bits that sit within NHS England and are part of the NHS contract for all provider trusts as well. So it's a really strong benchmark to work from, and I'll touch on some of the data in just one moment too. So moving into the data, this is some kind of quite wide-reaching data that I've brought from a variety of sources. On the right-hand side, it's from the Workplace Disability Equality Standards, WDES for short. So it shows that trusts that are rated outstanding in the CQC well-led domain have evidence of being better employers for their disabled staff. So very clear correlation there. Glassdoor, which is a kind of a recruitment website you may be familiar with, talks about 75% of respondents saying a diverse workforce is important to them when evaluating companies to join, and that rises to 80% for black people and 79% for LGBTI plus people. So again, as an employer, if we're looking at tackling the workforce crisis, if we get EDI right, we demonstrate it, we're going to get a more diverse and engaged workforce too. And then on the right-hand side, McKinsey, again, the big consulting company, shows that gender diverse companies are 15% more likely to outperform their peers, and ethnically diverse companies are 35% more likely to. So it's good business practice is the simple response to this. Sadly, on the bit more negative side, there is good and bad, or light and dark and everything. So again, go back to the WDES, Workplace Disability Equality Standard, 59% of trusts have 5 or fewer disabled staff in senior banded positions 8C and above, including medical consultants and board members. That was for their report last year, and their report is coming out later, I think this month or even in April. So I don't expect that picture to change too much. The RCN have highlighted in their report of June of last year that black, Asian, minority ethnic nurses are half as likely to be promoted than white nurses. So again, something quite shocking there too. And then just finally on the last year's staff survey, staff saying they're going to leave the NHS has risen from 26 to 31%. So a really stark picture there of why we need to get this right. Just moving on, again, some data from our colleagues at the RES team at NHS England. They have a really strong data set over several years since the RES has been running, and this is a really interesting one. So on the left-hand side, it shows there that if you, from the vaccine uptake, organisations with better RES metrics on the left-hand side had a better overall staff vaccine uptake. So again, looking after your staff, more likely to engage in vaccine uptake. They trust us more, basically. Right-hand side is maternity outcomes, and I think this is really fascinating. So maternity users with the better CQC ratings had better overall RES marking. So the more to the right-hand side, the better the RES marking, the better the CQC outcome. So there's a very, very clear correlation here, which is becoming more and more apparent. Sadly, though, if we're looking at the staff survey from this year, staff experience of discrimination is getting worse in every area apart from the other category, I think it is. And in particular, the top red bar is for black, Asian, minority ethnic people, and that's increasing quite significantly. So there's really a lot to do in terms of work here. And bearing in mind that over 25% of our workforce in the NHS is black, Asian, minority ethnic, it's a huge amount of people that we need to get this right for. And just moving on a little bit, and the reason why I'm showing you this data is that the RES team have very, very strong data. That we could do with better data is probably the other thing I would say is a takeaway here. So this is in relation to our system from the RES, which was published in March of this year. It's publicly available data. You can see on the right-hand side the different provider trusts in terms of their ethnicity makeup for their staff. The vertical purple line on the left-hand side there represents the average within our patch or within the provider land. The pink line shows the average across all the trusts within the NHS, right from near enough zero, right through to just over 70% for a London trust there. And then the two dotted lines are the average across NHS England. So you can see that we're quite far behind there in terms of black, Asian, minority ethnic representation. So that may be something that we wish to major on. Of course, we have to take into account the working age population of our neck of the woods, but it doesn't mean that we can't do it. And again, the NHS is one of the largest employers of black, Asian, minority ethnic people in the world. So it's worth bearing that in mind too. Just moving on swiftly to some of the data within the ICB, in particular our staff survey. So it does show hesitancy in people declaring their particular characteristics. You can see the prefer not to say bar is pretty much 20% across sexual orientation, gender, and ethnicity. So do people have confidence? Do they feel psychologically safe to declare their information? That would suggest possibly not. So there's more work being done. And currently there's a health and wellbeing survey that finishes at the end of this month. So I'd encourage anybody watching this who hasn't done it, please complete that. And in particular, fill in your characteristics, because people might, like me, love looking at it. And then this is a really, really interesting slide. So this is in terms of people who declare a disability who work within our organisation. So you can see almost 20% of people are declaring the disability. So a lot of work needs to be done there in terms of reasonable adjustments, things like flexible working and equipment, so on and so forth. But on the right-hand side, I think there's a really, really interesting slide in terms of people declaring that they are carers or looking after a family member. So that's an additional responsibility our people have within the organisation, and that's potentially people that they're helping not going into hospital or coming into our system. So how do we reward and recognise people and think about looking after them and supporting them in a better way? We have a staff wellbeing hub. Do we need to push more into that kind of neck of the woods? You'll be familiar with Core 20+5, probably far more than me, but I just wanted to put that out there to say this is incredibly important. We know that our people in our organisation and out there in the wider system are suffering some of the greatest disparities in this part of the world, but in particular thinking about our colleagues who are in work poverty, going to food banks and things like that. We need to think about how we're supporting them best and the impact on them individually. So what is next? So I've talked about all this stuff and said how brilliant and important EDI is, but what the challenge is. So as part of that 1 year interim strategy I mentioned earlier on, our vision is that we become the most equitable, inclusive, integrated care board within the health and social care system, creating fairer outcomes for all. And our mission is that we create an environment, a workplace and a system where our people feel that they belong, they're listened to, invested in and valued, and they receive equity of treatment and opportunity to see representation in their work and at all levels within the ICB, and that will embed and weave in EDI into the fabric of the ICB, creating that golden thread through the organisation in its delivery and policies to become the best place to work in healthcare in England. It's a bit of a mouthful, but what this means actually quite practically is on the next slide. So I've just put some, what I think are quite simple objectives. So in terms of improved EDI capability and knowledge, so that will be basically providing our people with this opportunities for learning and experience and development in all bands of the profession. I'm really pleased to say at the moment we're providing an inclusive leadership pathway for colleagues within the ICB. That's already kicked off, so thanks to those of you who've already been part of that. And we're working through some group sessions. So if people would like to nominate their colleagues to those, I'd really like to hear from you, especially colleagues in the local authority sector. That would be really useful to help shape a pathway. That's a year-long programme. We want to be legally compliant and confident, so that goes back to our point about PSED. We've really got to hit the nail on the head in terms of legalities, but actually looking above and beyond the statutory and mandatory elements in the health and social care system, so we're going to exceed our legal elements. And what we're doing in terms of that is looking at all our policies within the people sector and making sure they're fully equality impact assessment proof at every different stage. And then very lastly, just being consciously inclusive, so listening to our people to build the psychologically safe environment, improve their lived experience and create that best workplace environment, providing with the opportunities for them to perform at their very, very best. And what we're doing in that space is we've created a community online of NHS Futures of all the EDI leads within the organisation across all the provider trusts to ensure that they have a voice and they can share their learning and best practice as well. Thank you, Chair.
Thank you, Hamid. That's very clear, comprehensive report. Comments and questions? Is there anything you'd like to add, Sam? I'm sorry.
That's okay.
Anything you'd like to add before we go on?
Thank you for the presentation, Hamid. And I think the key point I just really want to get across is the business case for this is incredibly clear, not just across the healthcare, but across all businesses, having in work environments that are fair, are equitable, that everybody, whatever their personal characteristic or characteristics, feels valued and feels welcomed. It is incredibly important. So again, for me, this is about going beyond the statutory requirements. I think the other thing I'd like to say is I think for the North East and North Cumbria, I'm not sure how high on the agenda this has been as an issue. And I think partly that is because we know we've got significant health inequalities and healthcare inequalities in our communities, particularly with the number living in high deprived areas. Having said that, if you take even just one or two of these characteristics and you are somebody living in one of those more deprived areas, your outcomes are going to be far worse, far worse. And I think if we look at that from a workforce perspective, if you're an Asian doctor, female doctor working in the workplace, the evidence is likely to show that actually you're going to have a larger gender pay gap than your white counterpart. If you're a black mother giving birth, you're 4 times more likely to die in childbirth than the white counterpart. So this isn't a nice to have. This is absolutely integral to us enabling fairer outcomes for all. I think the key thing is we have to make this very relevant to our communities, but also to our provider organisations. And I think also support one another. So again, picking up the work we've done around our improvement network, taking an approach which is supporting improvement, enabling spaces to have what sometimes can be uncomfortable conversations in order to address the facts and what the evidence is showing us is going to be really important as we go through the next year. This isn't just about meeting our statutory requirement, it's about doing the best for our communities and also our workforce.
Rajesh.
Thanks, Chair, and thanks, Hamid. That was excellent, really excellent. And I think, Sam, you said something I've always felt. I mean, it's early days of the forming of the ICS, ICB, but probably this was a gap, this particular area about how we approach it, where we discuss it, what do we want to do about it. So it's excellent to see that. 2 points to make. I think you made some reference to outstanding organizations do this actually well. They still could do it better, but they generally do it well. And I think that really links into 2 areas. It helps with retention, number one. Yeah. And secondly, I think the first point, which was equity, diversity and inclusion. You diversity and inclusion well, you can move towards the equity aspects. Because many people in our communities, even though they are in pockets, if you look at some of the deprived communities, those from some ethnic backgrounds with protected characteristics, don't get the best access to services. So I think that's a quality aspect to it, along with the retention aspect. Yeah. And the final point was your last slide, I think, which was the objectives, which was great. What we would like to see in future is how you move further along that and how we get a common understanding of leading on those 3 objectives. I mean, the first 2 are great, but I think the third one is so important about creating that psychological safety and so on, which also links to a previous discussion we had on quality and safety and what we're doing around maternity services, and probably will link into Neil's discussion next about how we take on Core 20+5 and so on. So thank you very much.
Thank you, Rajesh. Kath.
Thanks very much. Thanks for your presentation. I was interested in one of your comments about how we might increase the support around additional protective characteristics, and just a little bit of a plea really. We're doing a lot of work regionally around care leavers and how we can ensure that children who've previously been in our care system are viewed in a similar way. So it was just to raise that, and there's a lot of work going on around the region in relation to care leavers currently, so happy to discuss if you ever wanted to.
Chair, for me, that's brilliant offer. I'd love to talk to you about it. We've actually got a pilot ongoing around care leavers. We just, yeah.
Yeah, so, I think I'm chairing that meeting. I chair that group, yeah, so.
Yeah, we should definitely catch up.
Great, thank you.
Tom.
Yeah, thanks, Liam. And as I guess this links in with Sam's point, really, and to coin a phrase, what gets measured gets done. And I know we've kind of flirted with in the performance report some of that inequalities monitoring in routine performance data, and I think it's great that we're starting to do that. I think there's something about how we kind of look at that as a focused topic, maybe on a regular basis as a board, so that we can look at how outcomes and routine performance does vary by some of the key characteristics that we've discussed today, because those gaps can be really quite stark, but sometimes get missed when we talk about averages across an area as big as North East and North Cumbria.
Thank you. Sarah.
So I just wanted to say a thank you to Sam and team for the appointment of Hamid. Hamid, that was a brilliant presentation. From Bill Kirkup's presentation, the thing that I took away was curiosity, insight and outcomes. And it's through the curiosity that you've developed within the ICB that we're now looking at this very important issue. And I'm very appreciative that it's been prioritised.
Thank you. Hannah.
Thank you. Yes, to echo that, really great presentation, food for thought. 2 things really. One, I was just reflecting on the importance of having the right data, and it goes back to obviously what we were talking about and the presentation that you gave earlier, Liam. But I was actually just flicking back through those slides, and what the data tells us really interestingly is about places, areas, and how we might answer some of your questions in relation to some extent. In relation to sort of sex, but that's about it. You know, most of the data there doesn't actually drill down and tell us about, okay, when we have the incidence rate of colorectal cancer, for example, who is actually represented in that statistic, and actually what are the inequalities within that inequality. So I think that's one thing that I would say about, you know, what kind of data is available, and actually how can we make sure that we're using that properly to get that thorough understanding. And then a follow-up kind of link point, I suppose, is that this is a challenge obviously for all organisations. I work at Durham University, and it's something that we've been grappling with for the last few years in particular. And one of the things that we've done is sort of introduced an EDI assessment in every piece of work that we do. Now, there is a risk of this sometimes becoming a bit tick boxy, but what it forces people to do is actually to assess every piece of work in relation to what the EDI elements are going to be, where the important issues are going to be, what they should be looking at, and actually to produce a statement that says whether or not it's compatible with the EDI strategy and policy and objectives that we have in the department. And it's forcing people to think about things that they wouldn't necessarily have thought about before. And there is a risk of it becoming a bit of an exercise, where you just do it for the sake of doing it, and there's monitoring needed to make sure that's not the case. But it does force at least a conversation to be started. Thank you.
If you want to pick up some of those points.
Yeah, no, thank you for the comments. It's really, really encouraging to hear. So I think in terms of, it's kind of the point you made about data, and also the point you made, Rajesh, about who's doing this well. There are organisations that do well but aren't amazing on it, but they may be good in one or two areas. So this is looking across the kind of the whole spectrum and beyond into non-protected characteristics, if I can call it that. I absolutely agree about the point about data, though. At the moment, we're working with some analysts within Next to kind of triangulate some of the data to understand where the kind of intersections are as well, which I kind of touched on there. So looking at kind of maternity and the impact, in particular, on Black women or Asian women in that sphere. Use of interpreters and language, so we can make sure that the health literacy is strong enough. So there's definitely a lot more work we can do there, and I completely agree about intertwining it with at every stage of what we're kind of trying to deliver, which is what an equality impact assessment is, and fulfilling public sector quality duties. So the framework is there. We just need to put the time and effort and commitment into it. I fully believe we can do that here.
Well, thank you, Hamid, and thank you everybody for your commitment to this subject, and we'll return to it, and we'll try and pick up the points that have been made, particularly some of the points about data. Neil, I think we've got time to fit in your presentation before the break, but we'll take questions after the break. That'd probably be the best way of splitting the time, I think.
Okay, thank you, Chair. So yeah, it's my pleasure to co-chair the Healthier and Fairer work stream with Amanda Healy, who's the current chair of the DPH network across the North East and North Cumbria. I'm just going to give you a quick update of some of the work that we have been doing and some of the impact that work has had to date. But it still is very early in its development, because we just decided on the 29th of November that says 23, that should be 22, I've just seen that, to set up the Healthier and Fairer advisory group, which is a subcommittee of the exec, and it has had its first meeting in February, and it brings together lots of pre-existing work streams to have a coherent strategy and some oversight to addressing some of the health inequalities that we've already talked about this morning. You may or may not be aware that there was a national amount of money given down to ICBs, which is over a 3-year period. We're about to go into year 2 of that, and our share of that is just over £13 million. We've had a very inclusive approach with our DPHs to look at how we best prioritise the spend of that money, and that's been through our executive as well. And these key work streams here that are listed, along with some evaluation of the work that we've prioritised, is what we've decided to take forward, and I'll be able to update board as these work streams start to get underway, and a little bit of an update on some of the waiting well stuff at the end of this presentation. So, as I say, it's 13.6 million, but we also have, through Next Transformation monies, an amount of money per year which we can look to prioritise towards these kind of areas of work. if we wish. We're looking to develop a performance dashboard which should be able to start using our data, our intelligence, to demonstrate progress in better and fairer outcomes for our population, looking at the core 20+5 for adults and children, etc. We've got a very wide and broad-based system partnership involved in our Healthier and Fairer group, and these are a number of the organisations that are involved. And as the group matures, hopefully we'll be able to demonstrate exactly how we are being very inclusive in our approach, because this is not just tackling health inequalities is not just for us as a system. The vast majority of this work is done through health and wellbeing boards and in our places, and local government have fantastic contacts in with industry, housing, education, all of those kind of things that we will need to address some of the challenges, as well as our emerging ICP structure. But the challenges are clear. Well over a third of our population is living in the two most deprived deciles, with all of the health challenges that brings. And our life expectancy, as we've talked about before, there is a gap, but we have an aspiration in our strategy to narrow that gap by 2030. Currently, there's a 1.6-year gap for women. We want to get that down to 1.2, and there is a 1.7 gap for men. We'd like to get that down to 1.3 by 2030. Now, this slide just shows a little bit about some of the underlying challenges that we have in the North East and North Cumbria. I've mentioned, obviously, the life expectancy differences. There is quite higher incidence of all-cause premature mortality, or preventable mortality, compared to the England average. We've got 13% of the population who are currently smokers, and I'll show that we have done some great work on that over the last few years. There is an issue with the adult population of being either obese or overweight, and that is also reflected in children. Our unemployment rates are higher than the rest of England. So, what contributes to the gap in the health in the life expectancy, and that's different depending on your gender. In women, it tends to be that the difference tends to be made up by cancers, but in men, actually, it's external causes, which include deaths from injury, suicide, poisoning, those kind of things, which is quite a telling statistic. And this has been termed the deaths of despair, which again is about 700 excess deaths for men and 310 excess deaths for women in the North East and North Cumbria. So I think this really does show or bring to life the effects that poorer standards of living, mental health, that can actually have on the outcomes and health and life expectancy of our population in the North East and North Cumbria, which is exactly why we need a multi-system approach to try and address some of this. So we have an aspiration, and we're working on an integrated suicide reduction plan, and our aspiration is to get our suicide rate down below the England average. This would be a reduction of 23 deaths per year. There's only three of our places that currently have below that at the moment, so there's quite a lot of work to do. We're doing a good job on smoking, but we can do more. And there's a few initiatives on the next slide to show exactly what we are doing. But there is a steady reduction in smoking prevalence in the North East and North Cumbria. A lot of the work that we've done in the previous 10 years plus, which can take credit for that. So we're looking to obviously our workforce are quite a large population of the North East and North Cumbria, and we're looking to support those with severe mental illness as well. The work that's been done in mental health providers to help those with severe mental illness to quit smoking really should be commended, and we're looking to embed that across all of our trusts, both physical and mental health, and recording smoking status when people are admitted and offering them intervention. And we match fund the Fresh across all of our places in the North East and North Cumbria, which is a structured approach to publicly getting out there, getting the message of the benefits of tobacco control, which is quite unique in the country. Alcohol, similarly, support for NHS staff, and we have supported 690 NHS staff to reduce their drinking within the first 6 months, and we're looking to embed alcohol recovery teams in all of our trusts, and there's some statistics on there on the number of people who have been helped by alcohol care teams, which have been as a result of our alcohol reduction programme. But we want to go further, so an alcohol team plus model, and then looking to develop some digital solutions and support for both the general public and our NHS staff. This is just a slide which shows the power that we could potentially harness of population health management. And we've used this to look at the health profile for those individuals with learning disabilities. We have a unique opportunity in the North East and North Cumbria, working with our partners in NEX to access the data within all of the GP systems, and we can easily identify parts of our population that might suffer from worse outcomes from any kind of health-related condition, either related to their some of their characteristics, such as learning disabilities or their level of deprivation. So we've got a well-identified population in learning disabilities. We've got a very high uptake in our learning disability health checks, but we can start now to use an approach to prioritise health interventions for this group to hopefully give them a better outcome. There is a link on there which really does, if you've not seen it before, 24 years life worth living, which really talks about the change in the life expectancy for individuals with learning disability. If you have time at some point, I would really encourage both to go and have a little look at that. It's a very powerful film. Waiting Well is a piece of work which I've been leading for a number of months now, and what we are trying to do is to use a population health management approach to look to either prioritise or intervene when individuals who are waiting longer periods of time for routine surgery. What can we do during that period of time when they're waiting to either support those individuals, because they may be experiencing significant pain, which might affect lots of other health conditions and their ability to work, and lots of economic issues. How can we support them with that? How can we optimise their health? How can we focus interventions around tobacco control, weight management, exercise, which will actually give them better outcomes following their surgery as well? So this work is using population health management to target those who are in more deprived communities and who have other characteristics such as learning disabilities. Now, at the minute this work is launching now. We've already had over 400 patients being contacted by a number of social prescribers, which are out within all of our places, but we coordinated across the North East and North Cumbria. And 190 people have accepted an offer of support. We'll have much more data as the months go through this financial year, which I'll bring back to board and hopefully be able to show you some real data on the impact of health improvement for those people who are waiting excessive lengths of time for surgery. But there's a quote there from a patient who had been supported both physically, had been directed to financial support, had been assisted with issues around their pain management and their isolation, which that holistic approach, as a result of the work from the social prescribing link workers, just really, led to this quote that before your intervention I thought I just wanted to die, and now I realise life is worth living. And I think, it is quite an impactful quote, but just does really demonstrate the value of that more holistic care that we can achieve within this defined population, but can be extended to others. My final slide is just to say this is this issue of health inequalities. We are at greater risk than the rest of England for this to widen over the next few years. This heat map shows the cost of living vulnerability index, of which the highest or the most vulnerable population are in Middlesbrough. But as you can see from our geography there, I think we are well above average to be vulnerable to cost of living issues in the North East and North Cumbria than other parts of the country. So it's absolutely essential that we embed this work. We have a structured way to try and reduce our health inequalities so that this issue, which we're all experiencing at the moment, does not widen our gap. Thank you.
Thank you, Neil, and we'll have some discussion on Neil's presentation after the coffee break. Let me just double check how long we've got. 15 minutes. 15 minutes. We'll resume at 11:45.
Yeah.
And just before we broke, we heard from Neil O'Brien, our Executive Medical Director, on the work that's going on health inequalities under the Health and Fairer, the new board, which is coordinating that activity under his leadership. And we're now going to open up Neil's presentation for comments and questions. Maybe I could start. I mean, as somebody who's been involved in championing health inequalities for a long, long time, I think the novel aspect of this that strikes me is the moving the inequalities agenda into care, because traditionally it's just been population health, and the Waiting Well is a very, very good example of that. And I think it's the reason that it hasn't been a feature in the past around the country is because it's assumed that the NHS is equitable, which it is. I mean, if you were to compare some of the healthcare experience in North America, you'd find big inequalities on the part of African Americans in access to things like coronary heart disease interventions and so on. We tend not to see that, certainly not on a large scale, but when you look below the surface at some of the mechanisms which are leading to people being further disadvantaged by the health system when they're coming from disease, it's a very big dimension, and I'm glad we're doing that in addition to the population health areas. But do people have comments and questions? Yes, Rajesh.
Thanks, Neil. I mean, firstly to say, I think what I liked about your presentation was sometimes this whole subject can be quite overwhelming, isn't it? Where do you start? But what I liked was there were some clear priorities identified and clear areas which I think would make a huge impact. So that's great. My question was about the reference you made to the mortality gap with people in our communities compared to the rest of the country and so on, and the work going on there. What I thought was missing, and maybe it isn't, but people with severe mental illness die 15 to 20 years earlier, and that is further heightened in our Northeast and North Cumbria. So is there anything specific going to happen with that group? Because there are bits happening through the Waiting Well project, Core 20+5 will add to it. But just like how you had the focus on learning disabilities with elective acute care, is there something about that particular group of people? Because that also links with the group which you call, who are sadly passed away or died due to the I think the words I had not heard them before, the triangle of despair or something which you referred to. So any observations on that?
So yes, there is a structured approach to the learning disabilities for health checks, and there is to serious mental illness. I don't think we perform as well as we could, and looking after that population for a whole multitude of reasons, either the way in which we are offering that health check, or the way in which those individuals' lives are structured, is stopping them from accessing that at a level that we would want to aspire to. So I think that there is some focused work looking at how we can improve that part. And working with mental health providers as well, who have most, or if not a lot, of the contact with these individuals, I think is hugely important. I think your question has highlighted there is so many more things that we need to get to, and that will help to narrow this gap. And there are so many inequalities once you start diving into some of this, and it is about prioritisation. And that is one of the early jobs of the board, is to say there is an awful lot to do. What are the early things that we need to do that will have most impact? And I'm certain this group that you're describing will be one of those.
Thank you. John Rush.
Thank you, Neil. I'm trying to pull some threads together of what we've talked about already, and what we've also said as a partnership that we want to achieve. And this is starting to do some of those things, because we've talked about preventative work, we've talked about inequalities, etc. And as you said prioritisation, I was writing down prioritisation, and so you said it exactly the same time. But the bit for me is I wrote down the programmes that you're doing, which was around alcohol, smoking, suicide prevention, cancer sort of prevention as well, screening, learning disabilities, waiting well. I was trying to grasp them. Because I think we need to, as a board and as a partnership, be able to articulate what are our 5 or 6 programmes that we are doing in the North East and North Cumbria that are having a real impact on our communities, and this is some of the data to show it. Now, I'm simplifying what is a very, very complex subject, but that's what we're doing. So you talked about the structure you've got, which is with the Directors of Public Health and with the clinicians and everything, so about prioritisation. And then it's the data we've talked about today as well, as how does that fit in within all that, because we can't do everything. But then again, the other bits we've also talked about is areas of good practice, and I just want to finish on the areas of good practice, because one of the things you talked about was suicide prevention. Over in Cumbria, massive suicide prevention programme, you know, to the extent, as I just mentioned to David, I also involved in running a village hall. In the village hall is something produced by the partnership. This is a suicide prevention box about all the different things you could do to help someone do prevent suicide. All the conversations you can have with individuals at work, which was done through, organisations, and how you speak to people and support people. The point I'm getting to is actually that's a really good example of going, that's good, can we replicate it, which I think is part of what you're saying. So I'm very enthused because we've talked a lot about waiting lists, we've talked a lot about maternity, all very important. This is about getting on the front foot. So thank you for kind of crystallising some of it for me as well.
Thank you. Sam, you want to come in on that too?
Yeah, thank you. Thank you for that, John. And I just wanted to kind of go back to our strategy, Better Health and Wellbeing for All, that we've signed off. And the Fairer Outcomes for All is one of the 4 goals in our strategy. And within that goal, where we've really set ourselves around reducing the inequality in life expectancy and healthy life expectancy at birth for people living in the most deprived 20% of neighbourhoods and by the least deprived 20%, by at least 10% by 2030. And we also have several other supporting goals, such as reducing smoking by 30% in adults by in 2020 to 5% or below. So we've signed off that strategy through our Integrated Care Partnership, and I think the paper Jacqueline will talk about in terms of our operating plan and our 5-year joint forward plan really needs to set out how we're going to deliver those and how we're also going to measure our progress against those. So I think we're clear about our goals and our priorities. The work we've got to do is actually how we're going to achieve it now. And I think Neil's point in his presentation around working with our partners on that, because we as an integrated care board can't do that alone, is going to be kind of really, really crucial. So I think one of the things we can do is make sure that we get our, as Jacqueline said, I call it our strategy deployment, we're really holding in mind our 4 goals and our priorities within those. And we've got a plan on a page. We can share that with colleagues, because we've got that true north now. The focus of that we need to do is the how we're going to deliver it, and also demonstrating back through here how we're measuring our progress against it.
Thank you. David.
Yeah, thank you, Chair. Probably just 2 comments, if that's okay, Neil. So about the money. So the first one would be, we obviously have around £7 billion of resources into North East North Cumbria ICS. And we will be doing a piece of work around how best do we deploy that resource, bearing in mind things like health inequalities. So I think that's going to be really important that we recognise that. We're going to look to support that reduction. And the second one would be, you mentioned I think it's at £12.4 or so million, which is a specific ring-fenced amount from NHS England, which sounds on its own a decent chunk of money, but it doesn't stretch very far, does it? And I do believe there would be value in bringing partners together. You had that map there of deprivation around the country. I use the word lobby, about trying to influence, actually, can we convince NHS England there's a strong case for increasing the amount of ring-fence funding for health inequalities? And I think that's something we can maybe look to do, not on our own, but with partners.
Just to say, I think that's a very key strength of our integrated care partnership, and one of the functions that we could do as if we act together as the North East and North Cumbria, then yes, that lobbying function I think is something that we could do.
Thank you very much. Jane Hartley.
Hi, just a couple of comments. You know, great presentation, and I'm obviously involved as Von is a partner with some of the work. And I think I'm pleased to sort of say that this does seem to be a totally cross-cutting piece of work that involves many different sectors and needs to involve many different sectors in order for it to be implemented. I would also just stress that the words adding life to years I would like to have seen in there, because I don't think it's just about extending life expectancy. And I think the quality of life of individuals, particularly the crisis that a lot of our communities are going through at the moment, needs to be factored in. I would just like to raise the issue around evaluation, Neil, and perhaps you can enlighten me, particularly because we're about to start some programmes contributing to some of these work streams, working with voluntary sector partners, and it would just be of value, picking up a little bit on John's point, to actually have some standardised evaluation in place from the beginning so that we can actually look at what works. And I don't know how far you've got with the discussions around that evaluation envelope for that piece of work. The other comment I would have is I think there's a great crossover with the learning and improvement work, because we do have some really good examples of what works at place and neighbourhood, and it's how can we ensure that those models are factored into some of what we're delivering through this programme. And so I just wanted to make those points.
Thank you. Neil, you would come in, and then Eileen's going to comment next, but she might have a word about evaluation during her intervention.
So yes, on evaluation, we've got an amount of money that's set aside because we absolutely recognise the importance of evaluating the initiatives that we have at the outset, and we're looking with academic partners of exactly how to structure that, and we can provide more detail of that as we go on. And I completely agree with your comments around the learning and improvement system. The example that John gave there from Cumbria absolutely does need to be shared, spread, adopted, and that is something that is a key function we see of the Healthier and Fairer group.
Thank you. Eileen Kaner.
Unsurprisingly, when it comes to evaluation, I've always got something to say. It is really important to build evaluation in from the beginning of these things, not just to use evidence to guide you as to what to do, but to figure out how best to look at the impact of the actions that are being taken. We've got some really good examples of working together across all 6 universities in the North East and North Cumbria in partnership on some of these initiatives. Neil's not had the time in the top level presentation to speak to that, but I'll just pull out 2 areas because I think it talks about the mental health issue. The Recovery Navigator programme, which involves all of the acute trusts. There is a partnership between the health and care system and 2 universities, Newcastle and Sunderland. And that's specifically looking at people who present to A&E with substance use and mental health difficulties and seeing where the support to navigate them to services in the community might lead to better outcomes there. There's another example looking at the long-term plan around hospital-initiated smoking cessation support. Colleagues in the ICS came to partners in the university and said, we want to evaluate this, will you help us? And we're working together. We secured over £380,000 to lead nationally on evaluating the rollout of the NHSEI initiative in hospitals. We're looking at all the trusts in this region as part of an exercise we're leading with 5 regions around England. So I think perhaps at a different meeting we might be able to come with some specific examples of working in partnership between health and care providers and those people who sit in the university system who've got the skills for evaluation. And I think there are many that we could just pull out to commend to the board.
Thank you, Eileen. David Thompson. David Thompson.
Thank you. And thanks for taking a lead in this, immensely important topic. But if I can ask a question, which I've probably asked before, so apologies for that in some ways. To what extent is your work influenced or even directed by the experiences of people who live in deprived communities who do suffer from health outcomes? So is their voice heard when you determine the priorities for your actions?
Absolutely, yes. I think what we need to remember is that this work is made up of all the work in all of our 13 stroke 14 places who have very well functioning health and wellbeing boards, who take in obviously a lot of the patient voice, elected individuals on there as well that are close to their communities, and obviously we partner with Healthwatch as well at a strategic level. So I think I'm satisfied through our place-based arrangements, and then that at strategic level as well that we've got the patient voice heard. But I'm always happy to hear of any initiative to try and strengthen that further.
Thank you, Claire.
Thank you, Chairman. Just to add to that, David, we've agreed from an executive point of view to make recommendations to the Quality Subcommittee that we set up a group called Patient Voice, which will triangulate all of the information. I think David referred to it earlier in his maternity presentation. That allows us really to look at the intelligence regionally, but also looking more down to a more granular level, at a local level, working with the local health watchers, but other representative bodies too, to make sure that we have a representative picture across all of our area.
Eileen.
Just one comment to speak directly to what David said there. All of the work that is being done in partnership with the Applied Research Collaboration involves co-production and public involvement and community engagement. Nothing will go forward unless public members are part of the design, the delivery and the dissemination of all the evaluations that we do.
Okay, I don't see anybody else wanting to comment, and that's a very broad range of inputs to your excellent presentation, Neil. So thank you very much indeed, and we look forward to hearing more about it as it progresses. We move on to the performance items on the agenda now, and Jacqueline Myers has got item 8.1 and 8.2. Then I'll ask you to take the two in sequence. I won't introduce each one separately. Jacqueline, let you go off with that.
Okay, thank you very much, Chair. So I'll start with the Integrated Delivery Report for February 2023. Just to remind you, this is a mixture of data for December and January, depending on when the final data was validated and available. As ever, it's a very detailed report covering a wide range of metrics. So in my presentation, I'm just going to draw out some key changes from the last report and leave space for questions, if that's all right, Chair. So just starting with the key points in relation to quality, I'm just going to draw out some changes in relation to CQC inspection updates. So there are 4 areas where we've seen notable changes that I want to draw out since the last report. There's been an inspection at North Cumbria Integrated Care NHS Foundation Trust, which has identified some areas of risk in relation to medical wards. So a range of concerns there, and a quality improvement plan is already in action. There's been 2 CQC comprehensive inspection reports published since our last meeting. So at South Tyneside and Sunderland NHS Foundation Trust, the report was published on the 3rd of February, and that gives an overall rating of requires improvement. And at the North East Ambulance Service, their report was published on the 1st of February and again gives an overall rating of requires improvement. And then finally, just in relation to a specific service, the British Pregnancy Advisory Service in Middlesbrough, they previously had a CQC inspection report which identified a range of concerns. And just to note that they have had, they've been in fact re-inspected, and it's been noted that their extensive improvement programme means that they've completed all of the required actions and the conditions imposed on their registration has now been removed. I'll just move now to some notable changes in relation to performance. And again, where I can, Chair, I'll bring in a bit more updated information where we've got reliable information beyond the publication dates that are included in the report. So first of all, in relation to handover delays, the board will remember that this has been an area of concern for some time for North East and North Cumbria, and as a result, an area where we've done a lot of improvement work with a wide range of partners. So I'm pleased to note that we've seen a real improvement in the position here, as is noted in the report. Up to the week ending the 18th of February, because this is something that we measure hour by hour and day by day, so we can give more up-to-date information. We were down to an average number of hours lost per day as 20, so really significant improvement. It's obviously early days in terms of this improvement being sustained, and we're continuing to keep a very close eye on it and work together across a group of partners, but a bit of good news there. Similarly, another key metric that we measure in relation to urgent emergency care is the number of 12-hour delays in accident emergency departments from the point where a decision is made to admit the patient to a bed. And again, this improved significantly, so there were still a significant number of delays, 1,583 January, but that is an improvement on December where there were 2,347. Again, another key metric that we're continuing to work on here, and as you'll be aware, this metric is closely related to the availability of beds in our acute hospitals. So all of the work that's been going on around improving safe transitions of care, I think Samantha, you described it as, so what we previously described as discharge, the improvement event that happened a couple of weeks ago and all of the actions that are coming through there, as well as some more day-to-day work we're doing where our chief nurse convenes regular meetings with all of our places to make sure that we progress this, progress patients through to transitions of care outside hospital, appertains to making improvements that in the end will allow us to avoid these delays in A&E departments to get access to a bed. Thirdly, in relation to ambulance response times, you'll recall we had a very challenging December. And again, I'm pleased to report that we've now seen 8 weeks of really significant improvement in our Category 2 ambulance performance times. So we've been on or under around 30 minutes after a peak of 1 hour 36 in December. We continue to perform well in comparison to the rest of the country on this metric as well, although again, we don't rest on our laurels, and it's another area where we're looking to further improve in the coming year. Moving on now to think about waits for elective treatment. Just to remind the board that the measure that we're striving to achieve in this current year, that just has a couple of days left to run, is to eliminate waits of over 78 weeks for patients, so that'd be a year and a half. The plan that we had as an integrated care board was to have no more than 180 patients waiting over 78 weeks. And that relates to some real significant challenges we've got in our complex spinal pathway. So in the report, it notes that at the end of December, we were down below 1,000 at 990. And I'm pleased to report that that progress has continued. We have seen some small impacts as a result of all of the strike action that we've seen in the hospitals, but we have done our best to recover the impact of that, and we expect to end this month with fewer than 180 patients waiting over 78 weeks. And obviously, as we go into the plan for next year, we'll continue to strive to eliminate those waits completely. And then finally, I just want to highlight the position in relation to reducing reliance on inpatient care for people with learning disabilities, and note that where this relates to adults, we are suffering some real challenges in achieving the improvements we'd like to see here. So as at the middle of February, we had 168 patients on our register who are identified as individuals who, whilst are currently in inpatient care, should be suitable to be cared for in the community. And that's significantly off track in terms of where we'd aim to get to, which is down to 71 in just over a year's time. So lots and lots of work to do here, really complex issues. We have seen some successful discharges across a number of places, but we've also seen quite an uptick in admissions. So it's a bit of a, I suppose, magic porridge pot situation I would describe. I think there's an opportunity here to do much better, and we'll be hearing more about this in future boards. So we're developing a comprehensive action plan with a real wide range of measures around how we work together with providers of care for patients who have complex needs but need to be given the opportunity to live in the community. So we'll bring that forward to a future board chair. So in terms of kind of by exception issues that I wanted to highlight, that's everything I wanted to say in relation to the report, but I'm happy to take any questions before we move on to the operating plan. Thank you.
Kath.
Thanks, and thanks for that report. Just a couple of things from me. Just it would be remiss if I didn't raise them. The issue around SEND and special education needs in the inspection framework, and the challenge that we've got with special school nurses is a real issue across the system currently. And I know that it's related to Newcastle Gateshead there, because I know from personal experience that what we're dealing with there. But that is a real risk and a real challenge currently. So I know that there's lots of work going on there. But the other issue will be is if when the SEND inspections really start to take hold, and I know Hartlepool's had theirs recently, so it'll be interesting to see what comes out as a result of that, because that is really about the local authority, the education services, and the ICB, and what therapies are being delivered across the system. So we will need to keep an eye on that moving forward. And then the other areas, obviously, children and young people with mental health issues and the challenges, because that is always raised in any inspection that is undertaken in relation to special education needs. So just to raise those as potential challenges for us.
Yeah, I might be able to say a little bit more of that when we get into the discussion on the plan, but certainly in terms of how we make sure that we've got sufficient capacity in our community mental health services, key issue there, and we've just been doing some additional work on that, which I'll be able to share in relation to the plan. Thanks.
Thank you. If there are no other comments, then can we move on to your second item then, please? Oh, I'm so sorry, Claire. No, it was from the leftover flag. Yeah, go on.
Thanks, Chair. I've actually got some slides. I think as we've heard already this morning, but just to reiterate, we're still working on the operational plan. We're expecting that we will get some extension to the planning deadline. So as we sit here today, we're still on track to submit a further iteration of the operational plan Thursday afternoon on the 30th, and we have made some real significant progress since I gave an update to the board on the sort of draft arrangements a couple of months ago. So what I'm proposing to do is first of all take you through the headlines at ICB level, well ICS level I should say really, the sort of, if you like, combined position across our providers on a range of metrics which are in the operational plan guidance this year as must-dos. And then you'll obviously get the finance plan update from David, and just to obviously make the point that the two things are hand in glove together. I think we've made really good progress in terms of the operational planning work that we've done this year, and I'm pleased to see what we've got to offer in terms of the plan delivery. It does present a significant improvement against a whole range of metrics compared to where we're at today. It's obviously the case, but just to restate, I think the health service as a whole is still in recovery from the impact of the pandemic, and we are still battling to regain levels of performance that were delivered prior to that. We've got a proud history of really strong delivery against these operational planning metrics across North East and North Cumbria, and we still benchmark really well, but overall across England, performance did take a serious dip and is still in recovery. So it's good to see that we've got a plan that presents significant improvement in terms of what we're able to deliver for patients compared to what we delivered this year, which was again an improvement on last year. So continuing to be on a track of getting better. So I'll just take you through the details, and then obviously again, Chair, take any questions. Okay, so this is quite small, I suppose, so I should probably just take you through this, but I'm just going to run through the headline metrics and let you know where we've got to in terms of the plan. So the first metric is about relating to A&E waiting times, and the operating plan guidance has set a target of no less than 76% of people attending A&E being either treated or discharged within 4 hours. And the plan that we've landed, well, I can't even see that myself here, so I'll have to refer to my paper. I don't know if these slides are going to work, Chair, I should say. I think it's a little small, isn't it, in terms of what you can see. It is 80.7, but I'm just getting to my... I probably do all know all of these by heart, but I'll pull it up. So it's 80.7 is the latest position in terms of what we'll be submitting, which is a good sort of 5, almost 6% above the national target. Still not where we want to be, but pleased to say that all of our providers are proposing a plan which exceeds the national ask. In terms of the next ask, which is related to those Category 2 ambulance response times, and just to remind you, Category 2 is for our most concerning conditions, things like potential heart attacks and strokes. We have got a compliant plan for the national ask, which is 30 minutes average across the year. So that's amongst the best plans that are being posted as far as we're aware across the nation. So pleased that we're able to offer a compliant plan in relation to that too. In terms of the bed occupancy, I have to say this has been a little bit turbulent, partly to do with the fact that alongside the overall plans that each provider is submitting in relation to acute bed occupancy, there's been the opportunity to bid for some additional capacity monies. And at various times we've been advised to include the impact of those capacity monies either in our plans or not in our plans. So the figure that you have on the chart here, which is 92.3, is not complying with the national ask of 92%, but that's without the impact of that capacity money. We were just asked on Friday to put it back in, and so when we submit the plans on Thursday, I think we'll be back into complying with that 92%. So we're just on the edge, but we look like we will be able to deliver that. Moving on then to the elective care measures, continuing the theme of reducing elective waiting times, the ask in 2023-4 next year is to get to a maximum waiting time of 65 weeks. That's a sort of halfway point between the 78 weeks, a year and a half that we were aiming for this year, and then the year after we'll be asked to achieve 1 year or 52-week waiting time, so 65 being the halfway point. So the plan that we've got for that is not compliant, not quite, but we really have done a huge amount of work. In our draft plan, we thought we might have as many as 700 people still waiting over 65 weeks by the end of next year. And through a huge amount of work that's been done by our provider trusts, working together to find solutions to treat all of those patients, we're down now to 14. It's Newcastle upon Tyne hospitals where we've got the particularly long waiting times, but they have now got plans in place with 4 other trusts to do some joint work, as well as plans to do some additional work out of hours with outsourcing teams and some use of some independent sector providers. So they've now got down to 14. Now you may wonder why with such a small number we can't just get to 0, but those 14 patients are all on one particular pathway, which is they're all patients with complex degenerative spine conditions who can only be treated by a very small team in Newcastle. And that team only manages to treat around 12 patients a month, so 14 patients represents more than a whole month's of work for that team. So this is where we've got to in terms of the plan. There are just 1 or 2 other avenues we're able to follow up, quite complicated. There's nowhere else in our region that can treat these patients. And nationally, across spinal centres who do the most complex work, there's a similar issue with an inability to get to that 0 plan. But we're looking at whether we can do some complex swapping of cases between trusts to create just a little bit more capacity. So unfortunately, when we submit the plan on Thursday, we'll still be saying we've got this 14 excess patients. But I wouldn't want to undermine the fact that many thousands of patients were waiting over 2 years not so long ago, and now we're getting down progressively to lower and lower waiting times. Just pushing on then, there is a target to reduce how many follow-up outpatient appointments we do compared to the number that we did in the year 1920, and that's to get down to 75%, and our plans at the moment are down to 89%. So it's not that's one area where we haven't yet concluded plans that are compliant. Challenging this, our providers tell us, particularly because, as many people will be aware, we still have some long waits for follow-ups, some delayed follow-ups, and there's concern about the clinical impact of cutting follow-up numbers right down to 75 before we've cleared that backlog. And we also have concerns from our colleagues in primary care that if we move too quickly to reduce follow-up appointments, that may put a massive extra burden on our primary care colleagues, and that, as we know, they are also extremely busy. So there is the opportunity to do better here, and our strategic elective board is looking at opportunities to redesign pathways in this sort of follow-up space to see if we can go further, but that's an area where we've not a compliant plan at the moment. Moving to the cancer standards, 2 standards are highlighted in the operating plan this year. One is to continue to reduce the number of patients who wait over 62 days on the urgent suspected cancer pathway, either to get a treatment or to find out that they don't have cancer and be discharged. And I'm pleased that we have got a compliant plan. We've seen good progress on this over this year, and further reductions there, about a third further reduction, which is good to see. Also pleased to say that we've got a compliant plan for faster diagnosis, which is that 75% of patients on that same pathway get a diagnosis within 28 days. So a strong plan there. In relation to diagnostics, there aren't very strong requirements in the operating plan, which is why we've not awarded ourselves a big green tick. It's just to do a bit more, and we do have plans to do that. We've got quite a bit of additional diagnostic capacity coming online during the coming year. I'll move us on quickly. And then again, just moving into the mental health standards, there's a bit of red text there to say there's the kind of more updates here. We thought we had compliant plans here when we did our draft plans. One of the frailties of the national planning round is that it focuses very much on the FTs and just ask them for their plans in relation to these standards for mental health, which relate to increasing access to services for children and young people, for adults and older adults, and in particular to the IAPT treatment pathway. We then recognised that we've got quite a wide array of providers in this space, and we had to go back and check all our plans at place level for community mental health providers. And I'm pleased to say, having completed that work, we're now confident that we have got compliant plans across, if you like, in the spirit of the measure, rather than just the plans that we'll be submitting on Thursday. So we're able to put a tick against those. The next target is in relation to out-of-area placements, inappropriate out-of-area placements for inpatients. And I'm afraid we've not got a compliant plan there. We have got an improvement plan, and a lot of work's been done to have a look at this. But at the moment, we don't feel we've got enough confidence in the actions that we'll take to say that we can put a trajectory to eliminate those for next year. I think this will be, again, an area that we'll do further work on in our 5-year forward plan to make sure that we've got more robust arrangements. In terms of dementia diagnoses and plans, we're able to post a compliant plan there. And then moving on to primary care, the ask is to increase the amount of primary care appointments that occur during the year, and we've got a plan that moves us from 1.4 million to 1.6 million, so that's compliant. We've then, I think, got a compliant plan around I think it's the learning, I can't see from here, but it's the learning disability health checks, which is a requirement in the plan. Moving down then to the final metric, which relates to reliance on inpatient care. We were just talking about this earlier, for both adults and children with a learning disability. Whilst we've got a compliant plan for children, we unfortunately have not got a compliant plan for adults. And this is something I think we'll want to look at more closely when we've developed our more detailed plan. I think the one that I didn't draw out actually, which I should mention, is the activity levels for electives. And this is a slightly complicated area in that the ask is that we do 109% of activity by value compared to 1920. Now, it's quite difficult to value a plan because it's not until it occurs and you know the exact tariff that you'll attract for patients depending on not only the procedure they have but other complexities that they have. However, we have got something called a ready reckoner, which gives us an estimate. And so we've just got that information through this week, and it looks like we have got a compliant plan that will exceed the 109% ask in terms of value, which is good news, not least because it secures a level of income for us to deliver that plan. We'll be looking closely at that to understand just how reliable that is, but at the moment it looks like we're compliant in relation to that too. Okay. In the pack, I've got a number of slides that give you a bit more detail in terms of each of the providers as well, but I think in the interest of time, Chair, I won't go through those in detail, but perhaps circulate them afterwards. But on this final slide, coming to that activity level issue, just some headlines there so you can see that we've got quite ambitious plans, I think, from our providers, and we should applaud that. So these percentages that you see, again, are compared to those 1920 baselines. That year's chosen because it's the year before the pandemic, and so that you can see that we're planning to exceed on all reporting lines, so first outpatients, electives, non-electives and so on. We've got diagnostics, we've got a plan to exceed all areas. So I'm pleased to commend the plan to the board. Thank you.
Thank you, Jacqueline. Open it up to comments and questions. Maybe I could start then. I'm conscious that this is national. These are national matters I'm going to ask about rather than things we've decided. A bit of clarification on the different terms that are being used. So we've got ambition, planning objective, and the word target doesn't appear anywhere. But I mean, basically, what status do these things have? Are they national requirements, and what are the sanctions for not achieving them?
It's a good question, Chair. I think they are variously described as planning objectives or ambitions is the word that's most favoured in this year's planning guidance. In relation to the elective standards, there is a financial penalty to not achieving the activity levels, and there are also, if you like, performance management regimes that apply where we either don't have a compliant plan, or we do have a compliant plan, but through the course of the year we struggle to achieve it. So I don't know if sanctions would be the right word, but where we've got concerns about the level of achievement in relation to a standard that's been set or an ambition that's been set, that will result in an intervention which will involve the right stakeholders getting around the table, having a conversation to try and understand what are the issues that are preventing that ambition from being achieved, and then a series of actions and supportive measures being agreed to try and recover the position. Can be a whole range of factors. It may be workforce related. It may be that there's been an uptick in demand, and so demand and capacity is not in the same balance that was anticipated when the plan was made. Or there may be other factors at play which will become revealed, so we kind of work through and try and understand the position.
Okay, thank you. John Rush.
Because what you're asking us to do as a board, because I'm clear to is to approve this submission as it is, and bear in mind some of those objectives aren't being reached. So that's what we say we're going to do or not do. But I also think as well the amount of work that's been taking place between yourself representing the sort of performance side, and I know David as well representing the financial side, because I know we're going to do them separately, but they do go hand in hand, because as soon as you increase some performance, that increases some of the financial potential for us to have to pay for it. So the point I'm getting to is actually, you're asking us to approve it. We know it's not compliant in terms of national standards, and that's the risk that we take. You've already answered Liam's questions in relation to what's the sanction about that. The point being is that, I mean, from a personal perspective, as a representative of the board, I've got to say that I don't know what else you can do at the moment, is where I've got to. And the same will apply to the financial bit. There might be a little bit more squeezing to be done, and it might go backwards and forwards, but you're also asking for that delegation as well. Again, and I personally would say yes, go, because we've got the timescales are running out in terms of what we've got to do. We're not going to have another board meeting to approve a further plan. It's probably the governance side of it that I was getting to, really. Yeah.
Yeah, thank you. I mean, I was going to suggest that we came back to that when we'd had the sort of two halves of the plan presented, but you're quite right. We're asking the board's support to submit the plan as it stands. As we've intimated, we think the planning round may have a couple more cycles yet, and we may well be back here with an updated version of the plan at a future board meeting. But certainly what we're wanting the board to do is acknowledge all the work that's gone into getting where we've got to, and give us support to take the plan at this stage through to the next bit of the process, I guess, which will be to get national feedback on it.
And again, I suppose as chair of the Finance and Performance Committee, you have been involving that committee in this process, so I just wanted to make sure that board members were assured of that. It's not just been the first time we've seen it, is what I'm saying. Yeah. Okay, thank you.
Okay, so we handle it in that way. Thank you. Well, thank you, Jacqueline. Thank you, everybody. Just keeping an eye on the time, we're running a little... Oh, sorry, David Thompson, you wanted to comment. Sorry.
Yes, thank you. Just something from page 184 in the context of a very thorough, open and honest plan. But it mentions in there a tremendous increase in GP appointments from 1.4 to 1.6 million. And I'm sure the public would be interested in knowing how you would achieve that. And secondly, the references to Learning Disability Register, 77% annual health checks. A colleague was asked me to ask you, that's high, but is it high enough, bearing in mind people with autism and learning disabilities, their high mortality rates? And the third one, if I may, there's no target for dentistry, which I can fully understand, because you don't assume responsibility until end of the week, and it is very early days. But it is a very, very serious issue, so presumably during the course of the year there may be some targets on that very emotive topic. Thank you.
Jacqueline.
Yeah, thank you, David. On your first question in relation to GP appointments, We've got an ambitious plan to increase the workforce within our primary care services, whilst unfortunately we're not expecting any increase in general practitioners because of various national issues around that. We have got overall a 6% increase in workforce in our general practices forecast coming in over the year. So it's a combination of additional workforce, because the appointment target is for all staff, not just for GPs.
Right, okay. Thank you.
And then in terms of the second point, I take your point entirely. I think the national ambition of 3/4 of patients who are identified as having a learning disability on GP practice registers getting a health check is not where it should be. I would just note that it's a relatively new standard. I think this will be the 3rd year that it's been in force. And so it's obviously a big push for GP practices to get to kind of to a point where this becomes business as usual and they're able to deliver it. As you saw from the presentation, we've got a plan that slightly exceeds the national ask, but I would expect that standard that ambition will rise over the coming years, and we'll see it lifted as we kind of get to the point where this becomes routine practice. So I take your point, but I think from a sort of standing start of none to get to 3/4 in a couple of years is not a bad start. We just need to continue to see that improve.
Thank you.
I haven't really got anything to add, Chair, in relation to dentistry, other than as we take the delegation, I guess we'll inherit a set of ambitions. We'll review those to make sure that they're fit for purpose from our point of view and incorporate them into our planning arrangements going forward. Thanks.
Okay, thank you very much. Right, we now move on to the 2 finance items, 8.3 and 8.4, and for those, the Interim Director of Finance is going to hand over to the Executive Director of Finance.
I'll start with the finance report for this financial year. Microphone. I'll just bring up some salient points. About the finance report, Chair, so I'll be brief if that's okay. So first one is about the ICB duty to achieve break-even on its revenue budgets. We continue to forecast a surplus of £2.7 million. We have received some funding this year for our independent sector pressures, so that's been pleasing to receive. Looking at the wider ICS duty to achieve break-even, you'll remember that we received £19.9 million of external funding from NHS England. There was a guarantee required for that we would achieve break-even against the ICS budgets as a whole, which is the ICB and the Foundation Trust together. The month 11 submission, which went in just the other day, confirms that we are on target to deliver that ICS break-even plan within a few £100,000. In terms of risk, there's probably now more risk around underspending or an undershoot than overspending. Okay, neither are great for obvious reasons. The main reason why there's a risk possibly of an underspend is because we have been receiving late allocations or late income for foundation trusts. So whilst that's good, it still gives a challenge for organisations in terms of managing their year-end positions. Last 2 duties, the capital duty as an ICS, not to spend more than our capital allocation. We're now on target to be just under our capital limit. That's following the receipt of some funding that's been long argued for around the CEDARS development at the Cumbria Northumberland Tyne and Wear Mental Health Trust. And last but not least, running costs. We're now forecasting to be around £4 million under on running costs. That's due to a reduced redundancy provision, some increased or reduced non-staff spending around things like legal and contracts with NECS. And there is a bit more consistency to work to do in that area across the former CCG area, so that number may still increase. They're the 4 points I wanted to get over briefly, Chair. I'll leave it there, if that's okay.
Okay, thank you. Any comments or questions? No. Okay, can you move on to the next one?
Yeah, thank you, Chair. So this is a verbal update on the financial plan for 23-24. Dovetails hopefully very nicely with Jacqueline's update on the operational plan. We did bring a paper to private board earlier today. In an ideal world, we'll bring a formal paper here today as well. We have noted earlier that producing a balanced financial plan for the ICB and the ICS, we noted that was going to be extremely challenging this year. We have been advised by NHS England to continue working to the wire. The submission is due on Thursday, and we are taking that opportunity to do that. It has been challenging. A number of key reasons for that challenge has been around a loss of £100 million of COVID funding for the NHS, low level of growth funding, and we have identified in this inflationary area that we're in approximately £127 million of what we would deem to be inflation over and above allocation. That's a huge sum of money in terms of managing the resources and producing a balanced financial plan for the ICS. We have agreed that the Chief Exec and I will review the financial plan submission that goes in on Thursday. As just mentioned before, that is unlikely to be the final submission. There's likely to be further ones, and we will bring a future paper to a public board meeting to say, here is the final plan that's been approved by NHS England that we've submitted.
Any questions or comments on that? No. Thank you very much, David. We move on, Claire, now to the Governance Handbook.
Thank you, Chair. People will recall we sat in this room on the 1st of July and we seen our first Governance Handbook. I did say at that point in time that this would evolve over time, and whilst it may feel like the painting the Forth Road Bridge, we are on to version 5 now, and hopefully if you look at page 200 in your paper deck, you will see all of the changes that have been referenced within the documents. Therefore, if we move to page 202, I am asking the board to approve the scheme of reservation and delegation, the revised, should I say, scheme of reservation and delegation, the revised functions and decision map, which is Appendix 2, the strategic and area integrated care partnership, which is Appendix 3, the approval of the establishment of ICB subcommittees at each place, the approval of the standard terms of reference for such subcommittees, that is detailed within Appendix 4, delegate the approval of place subcommittees' terms of reference to the Executive Committee, including any variation to the template terms of reference, approve the establishment of other subcommittees listed in Annex 1 and to approve their terms of reference, which is in Appendices 5 to 11. I appreciate there is a lot within that. There are a lot of papers within that. Obviously, this is really important given the transition into place-based governance and what we've had to set up as part of our governance infrastructure. I'm happy to answer any questions, Chair.
Are there any questions? John.
Sorry. Just one question. It's on page 200.
Microphone, John.
It's on page 280, and it's in relation to place-based governance. It revolves around, it says public or closed is in terms of the format of the meeting, like part 1, part 2. So question is that open to the public or that the minutes are being publicly made available, as in they're two slightly separate things? Because the only comment I would make generally is, I suppose as we've evolved as an ICB, we've gone from place-based arrangements and CCG arrangements, which were very accessible to the public and people could come, to like arrangements now, which are, I have to say, less accessible, but we're developing. So we've got, it's about going, if we're going back to place, will the public have access or not? Or what is it that people at a local place are doing about it? That's the question.
No problem, John. So first, two things. It's really important to note that we have not recreated CCGs at a place-based, and that's important. We have one governance infrastructure. Secondly, we have allowed flexibility at a place-based level for people to determine whether or not they have a public and a private part, and that is for local places to determine.
So they can work out if they want the public to have access, that's what they can do.
Correct.
Okay. All right. Thank you.
Dave.
Yeah, thanks, Chair. I think it's just worth reflecting that there's a need to have that flexibility, and it's welcome because we have different places that are at different stages in the development, and some are quite ambitious to get to be joint committees of the with the ICB. Others want to be committees of the ICB, and this gives us the flexibility to work with partners locally as we move through that. But do it safely. The key bit is this enables us from the 1st of April to move forward and get those arrangements in situ. So more work to be done. We can bring up an update back to the board as that develops, but it is really just getting this started and actually focusing on the work of the committees and then the governance supporting it rather than the other way around, which has always been a risk.
Okay, there's no further comments. Are you happy to approve the recommendations? Good. Okay, thank you very much indeed. So we've now got the committees of the board, and this is the section of the agenda where the committee chairs highlight matters that they've been discussing in committee which they think the board should be aware of. So Sam chairs the executive committee, and you cover two meetings of that committee in your report.
Yeah, thank you, Chair. And we've got the highlight report of the papers. Just to say, I'm very much looking forward to the place-based governance getting up and running, because as you can see, the extent of the work of the executive committee is quite significant, and certainly looking forward to many of these issues being addressed through the place-based governance in the future. Just in terms of the key points, there are sort of 4 key areas: the place-based working, particularly looking at the governance of that and the decision making, cancer care, predominantly with the focus around the clinical networks. We were anticipating at one point in time clinical networks transferring to the Integrated Care Board, but they are no longer now transferring. They're staying with NHS England. However, we will work closely with them. An update on our work around the commissioning of urgent emergency care centre for the Teesside area, particularly around the Middlesbrough community. And just finally, the primary care operating framework that we've established in the Integrated Care Board. The sort of the key risks, just to flag that we've noted for our risk registers around the community diagnostics programme, and Ken leads this on behalf of our system, working closely with the team. It would be fair to say we've got some concerns around ongoing revenue implications, given that the expansion of the diagnostic services have been funded up until 2025, but not beyond 2025. And just from a financial planning perspective, I think we will have to work through our Finance and Performance Committee and Audit Committee to make sure we are identifying funding streams that have got a timed effectively, so that we can start to plan for those in the medium to long term as an Integrated Care Board. Thank you, Chair.
Well, you've got the full minutes and summaries of the meetings in the papers for this board. Are there any other items or any matters that Sam's referred to that you wanted to discuss further? No. Well, thank you very much for the report. Moving on now to the Quality and Safety Committee. Eileen.
Thanks, Chair. Really, the slide relates to the meeting we had in February 2023. Some of the key issues covered. The Storyteller Protocol, we've stressed from the beginning how important it is to have lived experience, lay experience, contribute to our quality and safety committees. There's been a discussion where it'd be really valuable also to have a practitioner viewpoint. There is an extensive storytelling protocol. We had a bit of a discussion about whether the title of that was quite right, could get mixed up with language around telling stories or whistleblowing, etc. So there is a large comms process planned, and we just thought it'd be wise to stress test the language of that. We had a new contribution from the Directors of Nursing, who brought their top risks at place to the committee, and I think we have an ongoing conversation about what risk is best seen and scrutinised at place and what at system, and I think this is just part of a process to move forward on that level. I think the subcommittees that Claire has just mentioned helps us take a big step forward there, so place can deal with risk at place, and actually what comes to the Quality and Safety Committee are more system level risks that we need to understand and scrutinise. We had the flu update from Neil O'Brien, and then a reflection, a deeper dive really on the Bill Kirkup contribution from the last board meeting. Hannah Bowes, Vice Chair, led a session where we thought about what we were hearing at that presentation, and I think it's fair to say that we concluded that we need a deeper dive to move from what's known from elsewhere to what specifically we are going to do here to ensure that we've got respectful, safe maternity care across all relevant providers, and David Perdue has updated the board today on that issue. A couple of things to flag. Firstly, given when the Quality and Safety Committee began, we were slightly out of sync with board, so we were following on after. And there's been a request to me to see if we can get into sync with the board so we can meet ahead, and so that we share the same data with Finance, Performance and Investment Committee. So I believe we're going to skip the upcoming meeting in April so that we can actually move onto the right footing to be just ahead of the board meetings. And then I think there's something David Perdue and I met just last week or this week, really trying to think about what do we do from here going forward. We've had a long settling period for the Quality and Safety Committee. And I think now with the advent of the subcommittees at place, we're in a situation to think about how do we move beyond just seeing risk to thinking about how do we think about quality improvement. So it's rather than just being extremely risk monitoring, we want to actually slightly have a slightly more appreciative approach where we can learn from some of the innovations and the solutions being found by people in our health and care system, and actually try and think about quality improvement as a committee. So I think we really want to restructure our agenda, thinking about the pillars for quality and safety, which is safety, clinical effectiveness, and also patient experience, lived experience. And so we'll be taking a pause to think about how we structure the agenda going forward.
Thank you, Eileen. Any questions or comments on what Eileen said or the papers on this committee that are in the agenda papers? John, you come in first.
No, sorry, I'm not.
You go,
No question.
Or is it somebody's got? Is it Ken? You've got a red light on.
Oh no, I was going to do that for when I was getting ready to do my report.
Okay, all right.
I'm trying to get ahead of time.
Apparently, if there's more than 4 on at once, they all go dead and flash a green light at you. So you've got to can't have too many on. Sam.
Thank you. I think it's really positive to hear that you've been reflecting on the effectiveness of the committee. And I'm sure that's what all committees of our board have been doing so, given we're so new, and seeing how that evolves. I just wondered, in terms of that discussion, if there'd been any broader reflections around the whole of the integrated care system. So we use the language of patients and clinical effectiveness, but of course it's just part of our system. So just if there are any early reflections on the committee on that particular point.
Well, from myself, as has been raised in previous meetings, I'm care to think as a system, and we still don't have a social care representation on the Quality and Safety Committee, which is something that we're working on. At all times, we're trying to think about health and care. A lot of the risks we have and the solutions that we need to find are shared with partners right across the health and care system. So I think that's something that I've been thinking about. I think for me, we are where we are now, and we know what we didn't know, if you see what I mean. I think the early meetings have been very much about trying to establish the right composition of that committee, and it's nearly there but not quite there. And a lot of the early meetings have been focused on risk registers, which are hugely important, but we really have lost that element of thinking about, and so what do we do, and what solutions and innovations do we have that we might try to actually improve things across the health and care system. So I'm actually looking forward from here into the future about trying to have a more appreciative approach and thinking about improvement in all that we do.
Claire.
Thanks, and thanks, Eileen. And David and I have also had spoken around this committee, and it's just it's getting it's a fine balance, and it's making sure we've got the balance around assurance, given the statutory nature and the important nature of this committee, and the assurance that is required as part of that, the responsibility for that committee linking into the board. So I think it's sometimes quite tricky, but it's making sure that we've got the right balance.
I mean, if I could just add, because it's relevant to what you've just said, from my experience of this area, there's a lot of developmental work required, both in advancing patient safety, patient experience, and clinical effectiveness, as we saw from some of the earlier slides, including the blood pressure situation. So the developmental work as well as the assurance side of it. And basically, correct me if I'm wrong, but traditionally board committees are heavy on the assurance and not so much on the developmental work. But because we're a novel organisation, we're not a hospital or an organisation in that sense, it probably needs to be thought through how to create the right space for the developmental side of things as well. David Thompson.
Thank you. Just in a very, very general comment in response to Sam's question, the phrase golden thread has been used 2 or 3 times today. So I'm just wondering if the golden thread of meaningfully listening to the patient voice is threaded through, it is within the board, but threaded through the board, the committee's place, and everywhere where it should be, the thread of that is apparent and obviously so.
Well, I think it's uppermost in our mind, but you're quite right. We need to spread that that far and wide. And I think, interestingly, based on some of the earlier discussion, I think we're seeing a concept, the examples of Neil and Annie, of a story-based design of our system, which is, I think, even more powerful if those personal experiences or lived experiences are used to design the sorts of services we want. Now, there's quite a lot of people coming in. Let me just let them come in. Claire, quickly, please.
It was just in response to David's point. I think the ambition is absolutely there, David. I think we still have work to do, but I think hopefully what you've seen in probably nearly every conversation at board is actually a link to patient voice and how that influences what we're doing and how we're doing it. And I think, I'm sure there is more we can do. I know that there will be, but I think we've definitely got that ambition.
Eileen, we'll let you come back in. Let's just hear what the other 2 comments and then you can conclude. David, I've heard you.
Thank you, Liam. So I suppose it's a response to Sam's question. So what we're doing is, in terms of the integrated reports at place, there's a standardised agenda for quality, which is replicated in all 13, soon to be 14 places, which again is on those 3 pillars of patient safety, clinical effectiveness and patient experience, so bringing that through. And then we've just again looked at the terms of reference for the 4 ICP place quality committees. And so it all feeds up from place right to the board.
Thank you. Annie?
Yes, so my comments just in relation to best practice and also anticipating some of the understanding of what will come nationally, rather than focusing just on quality improvement, we should be talking about a quality management system which takes into account quality planning, quality control, quality improvement and quality assurance, and our language in quality committee perhaps reflective of that.
So final word, Eileen.
It was really just to come back to David Thompson. I should have said, and it was remiss of me to forget, that we had on the storytelling protocol some really helpful feedback from Health Watch, because I think there's something really important about how do we choose the stories to tell. So we've now got a protocol which is quite extensive about how we protect people and how we ensure that patient stories are part of what we have in our committee meetings. But I think we do need to give a little thought about which the stories we select and how that is done and how transparent it is. So thank you, David, for your feedback.
Thank you. On to the finance, performance and investment. You could put your red light on.
It was very premature, wasn't it, before? I'm not going to go into massive detail because we've talked about the finance, we've talked about the performance, because they were the issues that we were discussing at the meetings, really, and obviously in terms of those 2 key areas for us, for performance-wise, was obviously 78-week waiting and improvements in ambulance handover, which Jacqueline's explained. I suppose just a couple of things I want to say is we do have some minor, how should we say, bite-sized development opportunities before each meeting, because we went through a process where we, as members of that committee, worked out what do we know about some of these subjects that we're trying to deal with based on our terms of reference. So recently we've had inputs just for 45 minutes on prescribing. We've had some stuff on capital spend and what that means to us, just to gain our understanding of what that we have to do and what our responsibility is. We found very, very useful. So I want to thank the staff that have arranged those meetings for us, and we just do it on Teams before the meeting, and it's good. There was a little bit about risk assessment as well, because we're struggling a little bit, and we're going to have a future presentation, another bite-sized risk assessment process, just to try and link all those things up and how it's all going to all fit in. So really, again, the work that's been done by David and Jacqueline around trying to get the plan for 23-24, has been the focus recently, just in terms of trying to manage and land the final plan, the final financial side of it for 23. So I don't want to add more than that because you've heard the majority of it, but happy to answer any questions.
Okay, thank you. Any points or questions for John? No, thank you, John, then. And then the final item, unless there's any other business, is we have a question from the public arena. Claire.
Thank you, Chair. We have received a question from Jude Leatham, who is a coordinator for Keep Our NHS Public North East. Members of Keep Our NHS Public North East are very concerned to read in the North East and North Cumbria ICB Integrated Delivery Report for February 2023, Agenda Item 8.1, that a number of services within the ICS are inadequate according to the CQC. We are aware that the board have noted this. Please detail specifically what the board plans are for addressing this situation, given the requirement for the ICB to meet an overall efficiency target of £48.4 million. I believe, David, you're going to...
Yeah, thank you. So to be clear, in terms of our providers, nobody is rated overall inadequate. We have NIAS in their recent report in terms of where well led was rated as inadequate, and as part of that there is a support package that we have put together with NIAS to look at actually the elements of that, and some of that when you look at anything from the CQC, a lot of it is around process and ensuring that we have the right processes in place to deliver the outcomes. So and even when we look across wider, we've got people in enhanced surveillance, but that again is around how we support that in the mechanisms there. So just to give reassurance, there is nowhere that is currently overarchingly inadequate, and where we've got issues, we have got packages in place to support individuals.
Thank you, and we'll give a written response to that. So thank you very much, David.
And just to add, I believe the efficiencies mentioned there, they're not additional efficiencies that have been applied to any of those provider organisations. They would relate to things like prescribing and CSE packages of care.
Is there any other business? No? If not, with thanks to you all, we'll close the meeting. And just if you can confirm when we're off air, please.